For the
Got
webcast
it.
there.
Oh, the webcast. Everyone on the webcast, hi, how are you? So it's the interdisciplinary nature of the care. And if you look at the evolution of respiratory therapy, physical therapy in particular, those two have really have led the way in which we approach these patients, not only during their acute illness, but throughout their phases of recovery as well. So I'm really glad that we have a multidisciplinary representation here today, and because that's that combined care that has really made a difference over the years. So other than saying welcome and setting up the day, I hope you all enjoy it. There's a lot to be covered, and the workshops this afternoon also look to be awesome. Leanne, I'll hand across to you to introduce our first speaker. Bhushan.
We're all wearing mics because this is being webcast. Without the mic, the people on the webcast won't hear us. Okay.
Friends, it's a pleasure to introduce Dr. Cox. He's currently the Director of Pediatric Intensive Care Unit at Sick Kids, a legend in pediatric mechanical ventilation, mentor to many critical care physicians, and we couldn't have anybody better than him speaking on the history of mechanical ventilation. Dr. Cox.
Oops. Sorry.
That in your pocket.
Thanks, Bhushan and others. As Peter said, state of the art. Well, everything was state of the art once upon a time. So what I'm going to try to do is to give you a bit of a reflection of where ventilation has come from, really ending at the end of the last century, which for some of you was a long time ago, for some of us was very recently. This is a picture of an ICU. Very simple, not a lot of the mechanical stuff that we know today. But really, let's go back before that. And my slide's not progressing. There we go. So, Galen in the 2nd century had introduced the importance of anatomy and structure, but he didn't really understand the function of ventilation. And it wasn't until about 1,500 years later, 1543, that Vesalius, who was originally from Belgium, but ended up working as a professor in Padua at the age of 23, made this statement: but that life may be restored to the animal, an opening must be attempted in the trunk of the trachea, into which a tube of reed or cane should be put. You will then blow into this so that the lung may rise again and take air. After that period, there was a long period of time where nothing much happened in the field of mechanical ventilation, but interestingly, this is from 1770s. Joseph Priestley, who was an English clergyman, a great admirer of the French Revolution, worked near a brewery and noticed that if you collected the gases that were expelled from the brewery, that candles wouldn't burn in them. But in fact, if you took a plant and put it inside a glass jar, which is on your right, you could get that candle to burn again, or an animal to survive. He called this a phlogiston, and it wasn't until a little while later that Lavoisier, a Frenchman, who was ultimately executed for diluting or tobacco, actually identified this substance as oxygen. And if you think about what we do in our work every day, it's really focused on getting a molecule of oxygen down to the mitochondria. Cardiologists might think differently, but I just look at the heart as a pump to take the molecule of oxygen from the atmosphere to the rest of the body. So, people didn't really understand what oxygen was and why it was important, and many attempts at resuscitation were made. And this is a system of blowing smoke up someone's rectum while you're doing compressions in someone who's pulseless, and these were placed at various positions along the Seine River in Paris, used to resuscitate patients. So this is a bit of positive pressure ventilation. People tried different techniques, such as this one from the late 1800s from Gallereau. You take the aerophore pulmonaire and you force it into the airway, and you blow on it, but clearly not a very effective way of ventilating. 1907, during one of the wars, people were using mechanical ventilation, and they were using positive pressure ventilation, but the focus really became on negative pressure ventilation. This is from a guy in Boston named Alfred Jones in 1864, and he made these negative pressure boxes, which he believed could cure paralysis, neuralgia, seminal weakness, asthma, also deafness, and when judiciously applied, many other diseases as well. So negative pressure ventilation was seen as the be-all and end-all to keep people alive. And in fact, Alexander Graham Bell, who's best known for the telephone and establishing AT&T company, was very interested in many other things, including mechanical ventilation. And on the left is a picture of him and his daughter trying to resuscitate a sheep with a negative pressure ventilator. And you can see in the diagram on the right of this picture the cuirass that is around the abdomen and chest of a pig, and he was using this to ventilate an animal. 10 years later, in the top corner you can see the dates, 1892, he subjected Joseph McKillop, who was submitted to the experiment, and he seemed to succeed perfectly. While Ellis moved the bellows, McKillop stated that he made no effort to breathe at all. He had a piece of paper held in front of his mouth, moved backwards and forwards. So negative pressure was moving gas in and out of the lung. What this led to in the following couple of decades was the development of what was known as the iron lung. And Philip Drinker and Emerson were instrumental. It was in either the Philip or the Drinker ventilator or the Emerson ventilator or the both ventilator, which was an Emerson Drinker ventilator. Essentially what it did was it used a machine from a vacuum cleaner to suck gas out of the chamber intermittently. The patient's head, and I'll show you a picture of this in a minute, was outside of the chamber, and by changing the pressure in the chamber from 0 to minus an atmosphere, you could move the chest up and down and therefore allow the patient to ventilate. The problem is that looking after these patients was extremely difficult because they were stuck in a metal cylinder. So there were some centers that suggested that they convert a whole room into a negative pressure chamber, yet allowed the patient's mouth to be exposed to atmospheric pressure, and they would change the pressure inside the room to allow the patient to breathe, and you could therefore cohort patients together. Clearly the surgeons wanted their own space, so you actually created operating rooms. This is an example where patients had their head outside, the pressure inside the room was negative, and it allowed for operation. It was really the resurgence of polio that brought ventilation into sort of mass use. And this is a picture from a ward. There were about 70 patients in the ward, all on an iron lung or negative pressure ventilator. And you can imagine the congestion trying to look after this group of patients. Shandy would be pretty pleased to see that we were not only focused on looking after the patients and ventilating them properly, but also gave them the ability to communicate with others in the room. And surprisingly, and this is thanks to Anne-Marie, this is a picture of a guy called Paul Alexander. It's from the Independent last year. He's still on his mechanical iron lung, 64 years after getting polio, which is in 1952. So this is all negative pressure ventilation. And really, the polio epidemic, which happened in many parts of the world, but in particular in Copenhagen, was the watershed for positive versus negative pressure ventilation. Interestingly, in 1951, there'd been a polio conference in Copenhagen, and about a year later, Copenhagen had a dramatic outbreak of polio. And this slide demonstrates the number of cases being admitted per week, and you can see it goes up in the bottom graph to about 320, and a combination of both paralytic and non-paralytic polio. At that time, there was an anaesthetist called Bjorn Ibsen, and what he suggested to his boss, Lassen, was that they should use a tracheotomy and positive pressure ventilation and see if they could turn this around. This is an example of what they were doing, and I'd like you to note, for those who are not familiar, this is a CO2 absorber. Otherwise, the patient's CO2 would build up unless you've got a high enough fresh gas flow. But what Bjorn Ibsen was able to show was that there was a dramatic decrease in mortality on patients with polio, which initially was thought to be, the mortality was thought to be due to renal failure, but this really demonstrated it was purely a muscular problem. Before continuing with ventilation per se, I think what's also important about this time is that Mary Ellen Avery, who's this lady up here, and Jerry Mead had actually identified that surfactant was what the problem was in infants with RDS, premature infants with RDS. And it's 1959, but it was only in the 1980s that surfactant began to be applied clinically. Just a little bit of an historical note. So now that we've got positive pressure ventilation, like many things, you need to discover what else it does. And the same Jerry Mead, together with Collier, did a number of experiments in dogs where they anesthetized dogs, and they demonstrated that unless you gave them intermittent large tidal volume size, their compliance, which is on the vertical axis, dramatically decreased over time, which is on the horizontal axis. And this is an example here of periodic inflations or size, maintaining lung volume. No inflations, you can see compliance drops, and finally you get deflation. So we're beginning to see that lung volume, if you're anesthetized, is actually lost and you get areas of atelectasis. Another anesthetist and his colleagues at the time, Ben Dixon, did an experiment in the operating room where they subjected patients to anesthesia, and they either ventilated them with large tidal volumes, which is the graph on your left, or with smaller tidal volumes. And what I'd like you to note is on the left-hand axis is PaO2, on the right-hand axis is PaCO2, and there's pH up there. You can see that when you use larger tidal volumes, your PaO2 is well maintained. Your CO2 is low, in the region of 20, and pH remains the same. However, when you use shallow tidal volumes, in the graph on your right, your PaO2 dramatically decreases. So you're losing lung volume over time, and lung volume is correlated with PaO2. So the next step, I think, that was important in the history as we moved through it is the paper published in 1967 by David Ashbaugh and colleagues describing ARDS as we know it today. He said it was very similar to what had been seen in infants, and what was most important was that there was a theoretical relationship to alveolar surfactant deficiency, but most importantly, he stated that positive end expiratory pressure was most helpful in combating atelectasis and hypoxemia. So we're dealing at the lower end of the lung volume scale, and PEEP is now introduced. In infants, George Gregory published this paper in 1971, where they maintained premature infants on CPAP, and this is a picture of a little infant maintained on a bird ventilator, a baby bird respirator, just with CPAP, keeping up lung volume, maintaining oxygenation. So we're beginning to see that PEEP's important, maintaining lung volume is important, and the next slide is one that, I don't know, Brian can tell me how many times it's actually been shown. I know you...
Many hundreds.
Many, many hundreds of times. I think I saw a citation once of over 1,000 times. Anyway, so it goes on. What you can see on your left-hand side is a control lung, and on your right-hand side is an experimental lung that's ventilated with pressures of 45 on 0, and in the middle, they've added a PEEP of 10. And you can see the dramatic difference. Yes, the lung volume is increased, but the lung itself isn't hemorrhagic and damaged the way it is on the right-hand side with no PEEP. So PEEP is introduced, and when I was first in an ICU in the 1970s, the way that we got PEEP was to put a pipe in a bottle of water, and you'd slide the pipe up and down, and the depth of the pipe would establish what PEEP you were being used. Various other mechanisms have been used since. So the first ventilator that I was introduced to was this, which is a Bird, Mark 8. In fact, I had a Mark 7, then it was a Mark 8. Then I went on to this, which is a Blees Manley ventilator, commonly used in the operating room. And what's important to note is that on this ventilator, the tidal volume is established by sliding this little screw up and down on the right-hand side, and the inspiratory pressure is taking that big silver heavy block on the top and sliding it across the lever, and that together gives you inspiratory pressure and tidal volume. So these ventilators didn't have any of the sophistication that we have today, and we were using them at pressures that made the patient's lungs, the chest wall rise and fall, and gave us normal gases, which was our goal. In fact, when I first started in this unit, these were the ventilators that were standard. There's a Seacrest on the right-hand side and the Siemens 900C on the left, which was introduced in 1981. It's the old workhorse. It was an amazing ventilator. Even with these ventilators, we didn't really understand a lot of what we were doing in terms of lung injury, and the 1980s was really an eye-opener in terms of what we were doing to the patients that we were ventilating. The next slide is just another placeholder to remind you that pulse oximetry, which is now standard for all of us, was really only introduced by Aogi in Japan in 1981 and wasn't a standard of care until the late 80s. So all of those of us who were around doing anesthesia in the 70s and 80s, pulse oximetry wasn't in the operating room at all. We had a pulse meter, which was a little thing you put on your finger, and it flashed red every time there was a pulse wave. That was as much as it was. So the 1980s was the development of a big interest in lung injury, and this is a slide that includes a couple of pictures from different sources, but it really deals with the concept of a baby lung, which Gattinoni published a paper in 1987. What we think is homogeneous on a chest X-ray. Once we started taking CTs of the lung, we could see that, in fact, the injury to the lung wasn't homogeneous at all, and we were applying adult ventilator settings to what was really a baby lung and causing quite a lot of damage. So the concept of the baby lung is born in the 1980s. And then this gentleman is Charlie Bryan, who was my mentor, and as he was Des's. And I learnt an enormous amount from him. Charlie's most favorite diagram was this one, which is a PV curve. And for those of you who haven't seen this, on the bottom is pressure, and on the vertical axis is volume. And as you increase your pressure, so your lung volume increases. This is called the lower inflection point. It goes up to total lung capacity. And then what's important, and you can see this in the photographs at the top, as you decrease the pressure, the lung volume is maintained. So that, for example, at a pressure of 8, and on the inflation limb, you've got a lung that's got no gas in it, and on a deflation limb, you've got a lung that's nicely gas-filled. The other thing that Charlie did in his laboratory was he took an oscillator, and I can't remember, Des may remember exactly who did this experiment. I just know I got the slide from Charlie. But essentially, the difference between this and the previous slide is that on the vertical axis here, you've got volume, and on the vertical axis here, you've got PaO2. And it demonstrates very nicely, as you'd expect, that as you increase lung volume, you increase surface area, and therefore you increase PaO2. Now, using this kind of thinking brings us to another way of ventilating and maintaining lung volume. And in the thinking of some people at that time, it was to try and decrease the amount of lung injury. So I brought over here an oscillator that was developed by Katz Miyasaka, and it's not the same one that Des used in Beagle Dogs. I'll tell you about that in a minute. But essentially, this is a chest percussor. This is a bellows. And if you turn it on, it works as an oscillator. So Des never actually used that one, I think. Correct. So that's the first oscillator, and you can see the bits of duct tape. And this, in fact, says hertz, written in pen, 30 hertz, and that was the frequency that was used. So using an oscillator, this is now looking at ventilating a lung with smaller tidal volumes. This is from Charlie's lab, and you can see that these are rabbit lungs that are injured with lavage. They then get an inflation to regain lung volume, and with HFO as the top solid line, you can see that oxygenation is very nicely maintained, whereas the bottom is conventional mechanical ventilation without the same inflation maneuver. You do not get the same maintenance of oxygenation. The next slide, Des is in a much better position to explain than I am, but in experiments first done in pigs, they were unable to show that CO2 was cleared, but they then went and got beagle dogs, and Des showed that frequencies in the range from 5 to 30 hertz, you were able to maintain normocarbia. Just to take a step back, how did people actually recognize that oscillation would be able to get gas exchange? Charlie and Des and Katz were looking at impedance in the airway using a loudspeaker, and they measured the CO2 in exhaled gases and found that, in fact, it increased. So that was translated into using it as an oscillator, which has now become the sensormedics as we know it. So we're beginning to see smaller tidal volumes and smaller lungs and lung injury. And then in the mid-80s, Darioli and Perret, who published this paper in the American Review, which is the Blue Journal, they recognized that ventilation itself may be more dangerous than persistent hypercapnia. And this is a very small number of patients. They allowed the CO2s to go up into the hundreds, but decreased the risks of barotrauma and cardiorespiratory failure, and their patients did okay. As a result of that, Keith Heckling in New Zealand did a study looking at low-pressure limited ventilation, permissive hypercapnia, and this is a paper that really changed how much we needed, how hard we ventilated patients. Limited pressures to less than 30 centimeters of water, accepted a high PaCO2, and showed a hospital mortality that was quite dramatically different from the Apache 2 predicted mortality. This is a patient of ours in the ICU, and to show you that you can be conscious with a PaCO2 of 129, here he is. There's another marker in time. Nitric oxide, although it was discovered in 1980, it was only really introduced into clinical practice in the 1990s, and we used to get it from an industrial nitric oxide supplier in the corner of Davenport and DuPont. That was when it was still cheap. Just more on the theme of small tidal volumes and inflation, using the concept of recruitment of lung volume and then dropping your tidal volume back using a small tidal volume. We did a number of experiments in rabbits and were able to show you could do this both with HFO and with conventional mechanical ventilation. And Des might remember this slide is a little kid with a diaphragmatic hernia who'd been very sick overnight, and I'd like to take you to the time scale at the top. This is 8 o'clock in the morning. This is the morning ward round in the back. This is Charlie telling us to recruit the lung. This is recruiting the lung, and the saturations go from 50 to 98. So, evidence that it works. Our ventilation moved more in this direction, a safe window with proper lung volumes, and then work from Marcelo Amato, who happened to be standing next to us at the ATS in Seattle in 1992, cottoned on to the idea, and these are slides that you're all familiar with, that the peak pressure was much less in the low tidal volume than in the higher tidal volume patients, and the compliance was maintained. Just going to drop over that quickly and get to this slide, which is from our own laboratories here at the U of T, Art Slutsky and others, showing that not only do you have mechanical forces, which is pressure and volume, but you also have chemical forces that create this unifying lung injury problem. And I couldn't get away without having one slide to Brian, who showed using an adverse ventilatory strategy, you get increased translocation of endotoxin across the gut wall. So a lot of different information has really got us to where we are at the end of the last century, which brings us to this paper, which is the ArtsNet paper, talking about ventilation with lower tidal volumes compared to traditional tidal volumes and the impact on ARDS. And as you'd say, the rest is history. So I'll leave you with this statement. It's not what you use, but how you use it. and there are more uses than one for an ECMO machine. This is a standard Christmas party in the ICU many years ago. So there you have it. Thank you. Thank you.
Do you have any questions? Questions, comments? Dr. Guerguerian.
Discoveries do you believe were serendipity versus really intentional? Or do you, in terms of were they, and maybe comment on the
So for those of you that didn't hear, the question was how many of them are serendipitous versus thought through. So if you look at, for example, HFO was serendipitous. I think pulse oximetry wasn't. It was deliberate. And if you think about it, it's probably one of the major breakthroughs, certainly in my career. The tidal volume stuff over time was people waking up. If you look at when I first started, and in fact, Brian I brought in a patient yesterday that Brian was ventilating with pressures of 60. And I think it's understanding what you're doing and how you're doing it and what the implications are. The reasons for that happening was the patient had severe asthma with enormous overdistension. So to get back to your question, I think if you keep on thinking about what you're doing while you're doing it, something may happen serendipitously that will allow you to move down another path.
Thank you, Dr. Cox. Our next speaker is Dr. Brian Kavanagh, one of the staff intensivists at the Hospital for Sick Children.
Thank you very much indeed, Leanne. Almost. Thank you very much indeed. Kavanagh AM. Good to go. We're good. Yeah. Excellent. I'm afraid to touch anything here in case. Great. Leanne and Bhushan, thank you very much indeed. I'm going to talk about oxygenation during mechanical ventilation. I've got no financial conflicts of interest in this topic. In a single-blind study of pulse oximetry, which Peter mentioned, not serendipity, but a lot of effort. In fact, Bill New, the founder of Nellcor, in fact died last week. He was an alumnus of Stanford. And this study by Charles Cote, Boston anesthesiologist, Boston anesthesiologist, no more than all the other anesthesiologists, just in case you were wondering, did a study looking at children undergoing general anesthesia. And what they described as a major event, SpO2 less than 85 for 30 seconds, in my hands, that would be compulsory. That wouldn't be a major event. But nonetheless, it's a kind of an indicator that something isn't quite right and needs some intervention. And availability of pulse oximetry meant that those events were halved, essentially. And that was a big deal. That's not an outcome study as such, but if these are a kind of an indicator of worse things to come, then that indicates that pulse oximetry certainly gets you a little wiser. It's very important to know why your patient is hypoxemic. Peter talked about a patient who came yesterday. The patient came with the diagnosis of pneumonia for ECMO, and the patient has got asthma and is doing very well this morning. And the reason for that is because, the fellows on last night figured out, and the respiratory therapists figured out what in fact was wrong with the patient and were able to redirect therapy, and no ECMO, no pneumonia. So it's very, very important to always know why your patient is hypoxemic. So This is an example of a monitored cardiac arrest under anesthesia. When I used to do anesthesia, there were a lot of these. Just joking. This is a report, a very brave case report of a monitored cardiac arrest by Bob Byrick. Bob Byrick is someone who just retired actually a few months ago from active practice, former chair in the university department, and a man who had a lower rate of cardiac arrest than most anesthesiologists. But he and others were very interested in the phenomenon of fat embolism during anesthesia. And in the old days, you had an orthopedic surgeon about as tall as Des Bone and about as muscular as Peter Cox, if you can imagine such an animal. But to be an orthopedic surgeon, you needed muscles because you needed to hammer in the prosthesis with vigor. No namby-pamby sort of tapping things in. You needed a darn thing to stick. And in the old days, the prostheses were old-fashioned. And that hammering resulted in enormous elevations in intermedullary pressure and fat embolism, sometimes resulting in cardiac arrest and often resulting in neurologic sequelae ensued. It wasn't rare, it was common, but it wasn't understood. And Bob Byrick was one of the people who set about to understand that. So what you can see there is the pre-cement, the cement going in, the hammer, 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 a big monstrous blood gas is drawn, and then not very much blood pressure. Not exactly correlated, you can see the end-tidal CO2 is going down. It's not going down because the patient is being hyperventilated. It's going down because the pulmonary blood flow is being reduced. And in the same vein, the SpO2, probably an LCOR or Massimo pulse oximeter, you can see something is wrong. Now, the circumstance here, if you have an integrative approach, you'll realize that there is incipient cardiac arrest because the RV is full of fat. But if you don't know that, you would think, oh, SpO2 coming down, I'll fix it, I'll turn the SpO2 up, the FiO2 up. Fine, that's cosmetic. It may help the patient for a few minutes, but it does not address the problem. Worse, if you decided to do a recruitment maneuver on the patient, which under certain circumstances would be exactly the correct thing to do, but in this circumstance would end the cemented arthroplasty in short order, obviously. And so the low SpO2 treatment of that depends entirely on understanding why it occurred in the first place. I'll finish off with a slide about Dr. Barry Fairley, but this is a note. Barry Fairley started critical care in Toronto General Hospital with several others 60 years ago this year. He wrote an editorial on the subsequent study, a prospective study on pulse oximetry, and he made an important point about diagnosis and fixing oxygenation. And I'll read this out. As the blindfolded anesthetist, and I'm an anesthetist, and I hate to say that I'm blindfolded, but I often am, walks unknowingly towards the cliff of hypoxia, whether it's due to problems of inspired gas, equipment failure, under ventilation, pulmonary shunting. The protective hand of the pulse oximetry sentry stops him from falling over the edge. The pulse oximeter won't tell him or her why they have been proceeding in the direction, nor will it tell them the direction back. That's in 1989 when pulse oximetry was becoming established. And you can't imagine how important that is and how often even the most experienced practitioners will forget those basic lessons. What are the indices we use? We use many indices. We use P-to-F ratio. We all are very clear about what that is. Higher P-to-F ratio is sort of a good thing, really, we think. More benefit on the numerator and less cost, if high FiO2 is cost, on the denominator side, and a low P-to-F reflects the opposite. The OI is a more integrative approach. And on the surface, you would say, well, it contains all of the disadvantages, FiO2 and airway pressure. And so a high OI means you've got lots of hits onto the lung and not so much advantage. That would mean there's more cost and less benefit to the lungs. And the low OI suggests the opposite. And indeed, P-to-F ratio is quite closely related to mortality in pediatric children with ARDS, because in children with ARDS, the problem is predominantly pulmonary for the most part. And so the outcome and the mortality reflects the pulmonary function. In adults, it's paradoxical. Here we have exactly the opposite scenario, where you have on day 1 and on day 3, you have the lower tidal volume group who do better, have on each of those days a markedly lower PaO2 than the high tidal volume group who do worse. So it's kind of as if, on a superficial level, high PaO2 is bad for you. Well, no, that level of high PaO2 is not particularly bad for you, P-to-F ratio, but the means of achieving it with cyclic recruitment is very bad for you, whether it's with a ventilator or, as we're beginning to learn, with spontaneous ventilation. The importance of PA airway pressure, it's pretty important to understand how these things can be paradoxical. We're all familiar with the OI. Let's look at it in action. Here you inflate, you do a recruitment maneuver, and you imagine the lung is homogeneous, which in most animal models it is, and in early ARDS it can be homogeneous. Here you change the FiO2 from 0.6 and you reduce it to 0.5 because you've opened up the lung. The airway pressure has gone from 12 to 24. That's a big increase in airway pressure. And the PaO2 has gone up a little bit, which is great because the FiO2 went down a little bit. So your recruitment maneuver has kind of worked, so you think. And then you say to yourself, great, I feel good now. Are the lungs better? Well, if you look at the P-to-F ratio, they're far better. So that's great, excellent news. And then you say, well, what's the OI? Well, the OI is almost twice as bad. So you sort of pay your money and take your choice. You have to take an integrative approach, and you'd say to yourself, how much is this patient vulnerable with respect to FiO2? Probably not. How much is a high airway pressure helping or hurting this patient? And that's the way you'd interpret the OI, not as a single digit. Here's the OI in action on a pig model, which is a model of homogeneous ventilation. On the top curve, you can see it's animated, an inflation and deflation curve, and the red line at the bottom here shows that the optimal OI, PaO2, is with an airway pressure around about here. But the optimal OI, when you calculate it on a dynamic, is actually at a far lower airway pressure. And then if you look at shunt fraction on the very bottom, it's optimized across the whole spectrum. So the OI per se, you have to say, what do I want my OI to tell me? It's even more complicated because lungs, as we know, are not homogeneous. They're heterogeneous. Jean-Jacques Ruby produced these CT scans in the early 80s, where with color coding you can easily distinguish poor aeration, non-aeration, and overinflation. Look at the left column, 2 columns, 0 PEEP, and the right 2 columns, 15 of PEEP. What you can see in the bottom right of the lung, just down here, is dense atelectasis, which, when the PEEP is increased, the atelectasis is less. But that comes at a cost, because here, which was previously normally aerated, is now overinflated. So you get an advantage, better oxygenation. You get a disadvantage, more lung stretch. And it depends which is important to the patient at that time. So bad lungs, we call them bad lungs because we say they need high airway pressure or they need high FiO2. We seldom say bad doctors or bad respiratory therapists because they're getting, but they don't actually need, high airway pressures and high FiO2. And the only answer to that is presence at the bedside and titrating patients' ventilatory requirements to see what they need. Not every minute, but certainly every day. What do intensivists do in response to SpO2? Chong Wao was a medical student with me just the summer before I moved to sick kids, a fateful move. It's very bad news for sick kids, that was, but anyway, there you go. And he did in the old days of surveys, did a survey with a 100% response rate, which is pretty good among all of the chiefs of critical care in the adult ICUs across Canada. And he posed a bunch of questions. He said, well, when would you increase FiO2 at given levels of SpO2? Here you can see the response rate, here you can see increasing FiO2, and here you can see increasing SpO2. Well, in a basically 3D curve manner, more people will raise the FiO2 if it's low and the SpO2 is low. That's not all that surprising, but it's a general trend. The reciprocal was found for increasing FiO2. Now, this was a question which we framed in a different way. We said, if the saturation is 98% and everything else is stable, we gave them a good description, what would be your allowable FiO2? The answer, about 40%, but with a very big standard deviation. If your SAT was 85%, which we took to be kind of level when adult practitioners get nervous, and maybe everybody should be nervous, people said about 60%, but in fact, there's a far bigger standard deviation. So there's a lot of inconsistency in how people weigh these, not directionally, but quantitatively. I don't know if that's a bad thing, because I don't know what the actual answer is. Some people would say you want everybody doing the same thing. Well, yeah, but if it's all 100% wrong, you don't want everybody doing the same thing. So at least you have the benefit here, when we don't know, that you have some chance of getting the right answer and some chance of getting a wrong one. An integrated monitor is potentially more important. Didier Payan has worked in developing the tissue oximetry, which you put a oximeter on the thenar eminence, and then you occlude the forearm, and you see there that it diminishes the oxygenation, and then you release the forearm, and depending on how big a reperfusion slope you get a sense of the oxygen reserve in that tissue. That's been touted. It's a bit crude, but the idea is cool, that there is an integrated monitor that looks more than at just the saturation per se. Of course, Peter put his finger on the pulse, so to speak, when he said that the whole point is to get an oxygen electrode to the mitochondrion, and that's key because in sepsis, this work by Dr. Breakley and colleagues working with Mervyn Singer a long time ago did little muscle biopsies of patients with septic shock, tiny needle muscle biopsies, and found that you could differentiate survivors from non-survivors depending on the tissue ATP, which reflects mitochondrial function, and they were able to demonstrate complex 4 and complex Q anomalies in sepsis. So that would be going to a very, very end point in terms of oxygenation and its monitoring. I'll finish up by talking about an outcome lesson. And this is a lesson from preterms, but the lesson is generalizable. The exact answer isn't generalizable, but the caution is generalizable. And it's a two-part lesson. Dr. Aschke and colleagues hypothesized that in oxygen-dependent preterm neonates who are on supplemental oxygen, that the low normal, which was usual, was associated with no lung harm, but inadequate CNS development. So this SpO2 was prevented from going too high, but the problem was the kid's CNS was not great. It was basically a population problem. And the hypothesis was that if the SpO2 was raised a little bit, not to hyperoxic levels, then there'd be no lung harm, because you'd only get lung harm if you had hyperoxia, not high normal oxygen. And there's a capacity for better CNS development because the CNS is seeing more oxygen. Now, I have to say, you want to be pretty inspired to think that that's all wrong. I mean, back then, even now, except we know the data, that's a pretty sound basic premise. And here is the percent of time in saturation for the two groups. You can see here a standard saturation group and a normal, previously control group. So, I beg your pardon. So the standard is the control group, and the normal is the sort of, you try to push the O2 up a little bit, but not very high. And what they found, unfortunately, was no neurodevelopmental benefit. Well, that was too bad, because they'd hoped to get that, and it seemed like they were well set up to get it. The incidence of chronic lung disease in the standard group was 46%, and in the so-called normal group was 64%. Now, there's arguments as to what constitutes chronic lung disease, but what they'd hoped to get, they didn't get. What they thought they couldn't possibly get, they got. And that was a problem. So they learned from those errors, and they developed a formal hypothesis. They said, with a SAT of in the kind of highish normal levels, not really high, not 100%, not where you get hyperoxia, not PO2s of 130 and 200 and stuff, but pretty low. So if SpO2 is normal and a SAT of 96% is bad, and a 92% represents the status quo, then maybe a slightly lower SAT target is good. And this is a population study. This isn't individual titration, so it's tricky. Just a number that you apply to a population of what you think are homogeneous children. So there's a lot of assumptions there that definitely one size fits all. So that's the assumption. And how did that work out? Well, the targets worked out pretty well as they expected, and this was the 2010 support study. It turned out to be an extremely controversial study for all sorts of reasons of consent and so on. But looking just at the outcomes here, this is actually the exposure. So they managed to get the exposure in the low group. It's not low at all. It's kind of, you know, few of them in the high 80s, but basically clustered around about 90%. And the so-called high isn't high at all either. It's sort of mid-90s. There's a bell curve, of course, and you don't know what the activity is at either end of the bell curve, which is where your child might be lying. But this is what the population did. The second thing, though, was they had a composite outcome. We also have to be very, very careful with composite outcomes. A composite outcome of death or something like vegetative state, that might be an appropriate composite outcome, because in some people's mind, and some people's mind only, they're comparable. But, you know, a composite outcome, which is, you know, a brain hemorrhage versus a sore finger, that's not a good composite outcome because they're not remotely comparable. The composite outcome here was retinopathy of prematurity, which is a terrible condition, or death. Well, retinopathy of prematurity is not the same as death. And there are a lot of kids who have a very good quality of life who are blind, who have bad eyesight. So that composite was a problem because it was what the study was powered on. And what you can see here, the composite outcome showed no difference between the groups. So the kind of good news, and I don't mean this tongue-in-cheek, I mean it was when you break down the composite outcome, the retinopathy of prematurity was substantially lower, i.e. better, in the low target group. But unfortunately, death was slightly but significantly higher. And that's actually quite a significant increase in mortality, which you can see here. If this was a cardiology study with STEMI or beta blockers or something, this would be the biggest difference you could ever imagine and would have a trial of 100,000 patients. That's the way it works. So this is a very big difference in mortality if you imagine many tens of thousands of premature neonates. So putting all that together, there's a big note of integration and caution. We get back to Dr. Fairley, who was the senior author on this paper. After he left Toronto, he went to UCSF, where he became vice dean, and then went to Stanford, where he became chair of anesthesia. And Peter Suter was his fellow, who's just recently retired as rector of the University of Geneva. And this is a study called Best PEEP, Optimal End Expiratory Pressure. And essentially, probably this study doesn't quite work out. Probably quite hard to reproduce exactly this study because the patients weren't all that characterized and so on. But the bottom line is what they looked at was the relationship of the y-x-axis, which is changing the PEEP, on venous oxygenation, AVO2 difference, total cardiac output, and O2 transport. And the bottom line is not whether you can get a best PEEP for a population. The bottom line is that when you change PEEP, you change all those components of oxygenation. And that's the whole lesson. So I will summarize by saying there's no magic index. P-TEF, OI, I know Desbone loved the OI, but only compared to P2F, or best PEEP. You must titrate. You must integrate all of your knowledge, like the orthopedic surgeon and Dr. Byrick in the operating room. You must consider all of the issues. You must understand what you're doing or strive to understand it. You must be present, which means you've got to keep coming back and looking at the patient, and you must think and reflect. Thank you very much.
I'm not reaching your book. Thank you very much, Dr. Kavanagh. Does anybody have any questions? Now, while we're setting up, I'd just like to bring your attention to the back of your program. There is a Twitter feed that we are looking at. So please, if you're a social media fan, please go ahead, tweet, You can, I'm not part of that, so I can't tell you how to do that. Yeah, no. There are other ways to get a hold of us. And for those of you who are on our webcast, if you have any questions, please email them in. Bhushan here will answer your questions and direct them to the speakers.
It's a pleasure to introduce Dr. Ferguson. He's the Chief of Critical Care Medicine at University Health Network, a leading trialist in ARDS, and he's going to speak to us about HFO learnings from children. Thank you, Dr. Ferguson.
Great. Thank you very much, Bhushan. I'll just get, clip this on here. So it's a pleasure to be here. It's always a little intimidating to come to see. I think this is the third time. Okay, for those listening on the webinar, you missed 5 minutes of extremely interesting talk. And we're on the slide that shows the HFO glass circuit. And then, so we're pushing and pulling air in and out of the patient. And downstream, we have a little mushroom valve which controls the resistance at the end and allows us to maintain and regulate mean airway pressure in the circuit. And some of the cool things about this is that we have, by definition, it's high frequency. So we're talking about respiratory rates that are high enough. It's easier to talk in cycles per second instead of breaths per minute. And tidal volumes are generally less than the anatomic dead space. We also have nice separation between oxygenation and ventilation. So oxygenation is dependent on lung volume, mean airway pressure, and FiO2, obviously. Whereas ventilation is relatively independent of that and related to the force with which you move the piston or the membrane and the frequency. And as I said, people spent their careers trying to figure out all of the different mechanisms by which CO2 is actually effectively cleared despite having a very small tidal volume. Art Slutsky and Jeff Drazen wrote this nice editorial in the New England Journal several years ago, which summarizes at least 6 or 7 different mechanisms, but they mostly have to do with enhanced gas mixing within the lung. I'm not going to go into that too much here. So I'm going to take you a little bit, the talk's supposed to be lessons of children. I'm going to take you through a little bit of the adult story first, and then go back to designing a randomized trial for HFO and the lessons and the thinking that we took from the neonatal and pediatric world in that design. So remember that for the first 10 or 20 years of practical HFO experience, neonates and children were able to be oscillated, but the maximum weight on the Sensormedics 3100A was 35 kilograms, so it wasn't very useful in the adult ICU. And then in the late 90s, they developed a new version of this machine, the 3100B, which had a more powerful driver and now was supposedly available to shake adults. And we started using this in the adult ICU, and Toronto was one of the, naturally one of the sort of the vanguard centers of this. Geeta Mehta nicely summarizes the experience in adults, and this was really used as rescue therapy for patients who were failing conventional ventilation. And there are enough, you can look back in the literature and find 8 or 10 case series of adults. We took patients who were really sick. We thought they were going to die anyway. We put them on HFO, and what happened? Well, we increased the mean airway pressure. And over the next 6 to 12 to 24 hours, we saw a reduction in the required FiO2, an improvement in the PF ratio, and a reduction in this thing called the oxygenation index, which was a new marker for us in the adult world, but well known to those in the pediatric ICU. And so this, with the conclusion here was that, HFO looks to be safe. Yes, people are dying, but very, very sick to start off with, and they maybe weren't dying as much as we thought they would. Certainly, it seems to improve oxygenation in survivors. Might be very appropriate as rescue therapy. And then around that time, one of the first randomized trials of HFO came out. This was the MOAT study. I can't remember what the acronym stands for. It doesn't matter. Just need to have a good acronym so people can remember what your trial is called. This was a study funded by the company with a goal of getting FDA approval for the device. The primary outcome was adverse events between the two groups, which were not different, and so they were happy. but there was this enticingly large, but not quite statistically significant difference in mortality favoring the HFO group, 37% mortality versus 52%. Now, this was done in the mid to late 90s, so the conventional ventilation arm would not be what we would call best conventional ventilation in 2018. Tidal volumes were on average about 9 mils per kilogram, and PEEP was a little lower than you might want to see it today. But at the same time, we might also say, oh, they used HFO a little differently than we might today also. I think the bottom line on this was that, again, no safety concerns here, maybe it improves outcomes, very encouraging hypothesis-generating study. And this wasn't in isolation. Sachin Sood here put together all of the randomized controlled trials outside of the neonatal setting, so a couple in children and several small trials in adults. And you can start to see a positive signal coming out in favor of HFO influencing mortality in a good way. People were jumping on the HFO bandwagon in the adult world. And this really gave us the impetus to try to get this trial together, which was the trial that Maureen Mead and I conducted together. I try never to show this slide without showing this slide, just to show you that there's hundreds, literally, of people have to work to get a trial like this together. This was funded by the CHR and conducted in collaboration with the Canadian Critical Care Trials Group. So how did this trial come about? What was our thinking? Because, spoiler alert, the trial showed increased harm with HFO. So why did that happen? And how could we have been so stupid, if you listen to Didier Dreyfus, to have designed the HFO arm so badly? Well, I'll tell you how it happened. This was an international, multi-center, randomized trial. We started with a pilot phase, which was really just focused on feasibility and convincing CHR that we could actually do this. We didn't look at the clinical outcomes during that time. We rolled those over into the main trial, and then continued with active recruitment for another 3.5 years. The control arm, the comparator arm, was what we thought was best conventional ventilation at the time. We were trying to compare an apples-to-apples approach. We wanted to do open lung with HFO, and so we didn't want the criticism to be, if we showed a benefit with HFO, we didn't want somebody to be able to say, well, all I needed to do was actually just turn up the PEEP on the conventional ventilator, and I could have done the same thing. I don't need your fancy new machine. So we went through and said, let's do high PEEP, low tidal volume conventional ventilation based largely on the intervention arm from the lung open ventilation study shown here. For the HFO arm, we wanted to get to this principle of oscillating on the deflation limb of the volume pressure curve here. And this was informed largely by work from sick kids and others thinking about how HFO worked in neonates and in the animal lab. So you may know this trial, the HI-FI study, was the first RCT of HFO in neonates, almost stopped the technology in its track when it showed similar rates of bronchopulmonary dysplasia and similar rates of mortality, but lots of increased adverse events, things that I don't see in the adult world but sound very bad, like periventricular leukomalacia, and certainly intracranial bleeds. Those are bad. This was very concerning. But again, some smart people took some time to think about this as well. It's not just the machine, it's how you use it. And here, the goals were not about increasing lung volume and recruitment. They were about weaning mean airway pressure and leaving FiO2 high. And it's a technology that has a learning curve, and there were very large between-center differences in these adverse event rates. So eventually, obviously people were able to overcome this initial result and got back on the horse, thinking about lung recruitment and recognizing that it's not just the lower inflection point of the volume pressure curve, as we were focused on in the adult world in the late 90s, but in fact, recruitment is happening throughout the inspiratory limb of the volume pressure curve. And it's when you get to the upper limb that the lung is open. Alison Fraser wrote this editorial for another one of these initial rescue series in the late 90s, saying, okay, let's think about this and be smart this time, try to get patients into this safe window. And how to do that? Probably with recruitment maneuvers. Yes, there's some inconsistent results when you talk about conventional ventilation, but we thought there was a strong case for recruitment maneuvers with HFO because of a lack of tidal recruitment. They may be of more use, and maybe they're more effective because we could set mean airway pressure, or functional PEEP, higher than we could on conventional ventilation. And there was some animal data to back this up. If you were a saline oleic acid lavage rabbit, if you didn't get a recruitment number, you died after 4 hours of conventional ventilation, so we thought that was bad. And how to figure this out? Well, we wanted to use oxygenation people as a marker of lung recruitment. Put this review by Brian and Joanne Meyer up, showing that just because numbers are normal, it doesn't necessarily mean that they're good. But having numbers be in target depends on how they got there. So people say, oh, raising oxygenation is bad. We know that from the ARDSNet study. But no, that depends on how you do it and why you do it. When we're using oxygenation as a measure for lung recruitment, not necessarily bad. So we were able to show in a physiologic study that ramping people through a series of recruitment maneuvers, we were able to recruit the lung. And we thought this is important because there were major differences between the amount of airway pressure that were transmitted to the lung, to the trachea at least, on HFO, depending on the state of lung recruitment. Again, these are different animal experiments here. The other thing we were focused on, so that was one part of our learning, was that, well, we want to do HFO, we want to use lung recruitment. The other part was thinking about what actual tidal volume is recruited, is being delivered. And there's no measure of tidal volume on the 3100B or the 3100A for that matter. And in the early 2000s, we had some a little bit concerning data from Bob Kazmarek's group showing measuring tidal volumes in sheep of 120 mLs. But in a sheep, that's 4 mils per kilogram when you're using high amplitudes and lowish frequencies. And we were very routinely using frequency of 3 and 4 in the adult world at this time. Dave Hager from Hopkins here used a different technique to measure tidal volume and showed that you could actually deliver low tidal volumes to adults, but it didn't happen automatically. So the other thing that we set out to do with our protocol was, and it was basically on these two papers, was to try to recruit the lung using recruitment maneuvers and at the same time deliver the lowest tidal volume possible by ramping up the frequency so that we were taking advantage as much as we could of the sort of gas mixing properties of HFO as opposed to bulk conventional ventilation. So this on day one resulted in our protocol basically gave high mean airway pressures, a mean airway pressure of 31 as measured compared with 24 on conventional ventilation. I'll point out though that given the drop off in mean airway pressure when you use an IE ratio of 1 to 2 as we did, this maybe isn't that physiologically different if we had been able to measure airway pressures in the trachea. And these spread out over the next couple of days. And as I've already told you, the results, surprising to us and disappointingly, showed higher mortality in the HFO group. And when we looked at these all different, so there must be a positive signal here somewhere. Even all of our pre-specified subgroups were on the wrong side of the line, favoring conventional ventilation. In the same issue of the New England Journal, a UK study, I don't have time to go into all the details here, but suffice to say they showed no differences in mortality. So what happened just in the last couple minutes? This slide summarizes what we tried to do in blue and what might have happened in red, some possible explanations about why we saw these adverse events. So in our efforts to recruit the lung, we used higher mean airway pressures, and it's possible that we had higher impact of hemodynamic compromise, and maybe we had failure to find the optimal mean airway pressure because of a lack of lung recruitment or overdistension. We tried to have the highest frequency possible, but we may have failed to achieve this and delivered higher tidal volume than anticipated. And there's also the issue about resonance frequency, where in adults we may have been oscillating. I think we know what the resonant frequency is of a neonate, and it's somewhere in the 6 to 8 hertz. And so when you're oscillating at 12 to 15, you're not anywhere near that. But I think in adults, the resonant frequency is probably quite variable. And in some patients, we may have been oscillating in that resonant frequency. It's complicated physics that I don't completely understand, but it propagates waves instead of diminishing them as they go into the patient, which may have amplified the power we were delivering to the patient. Bottom line is we knew going into it that there were going to be some detriments of HFO, but we thought that these would be outweighed by the benefits of improved lung protection, and at least in these patients and in our protocol, that proved not to be the case. It's not completely the end of the story. In a individual patient data meta-analysis combining all of the patients from OSCAR and OSCILLATE and the two MOTE studies, we did find a very interesting interaction here, showing that baseline PF ratio was an important effect modifier. So this is a pre-specified analysis which shows that depending on your degree of hypoxemia before going on HFO, if you were below 100, or if you want to be more conservative, below 64, where the 95% confidence interval here crosses 1, HFO was helpful. If you were above 100, HFO was harmful, which goes back to how we were initially using HFO in the first place. When we did that physiological study I did in the first place, the first step was put patients on 100% oxygen because we wanted to have comparable blood gases as they transitioned on to HFO, and we only included patients whose PF ratio stayed below 200 on 100% oxygen. Turned out that was a significantly sicker group of patients with a much more severe degree of lung injury, as seen here. All of these patients had severe ARDS, even on 100% oxygen. So I think that we had seen some creep in clinical practice in adults, where we were applying principles of HFO to patients with relatively less severe lung disease. Maybe they weren't as recruitable, and we were seeing the adverse events of trying to recruit somebody who's not recruitable or who already has their lung open, compared with our benefits. We started off trying to test HFO across this spectrum of severity, and I think at the end we end up here that maybe still a role in the severe ARDS, refractory hypoxemia case in adults, but not as broad as we had hypothesized. Maybe the story's not completely done. This was written in 2001. The last paragraph from Charlie's paper here is this: the story's not finished. There are a number of studies that still need to be done before we blunder into another premature RCT. A major problem is safe and effective lung recruitment maneuvers. There are a number of ways to go. We need to test this in the laboratory. We're still working on this. Thank you very much. Thank you. Oh, thank you very much. Questions? Des?
Would you always try HFO before you consider ECMO in adults?
So it's amazing how people talk about changing clinical practice and how hard it is to change. We saw a huge swing away from nothing like a trial showing harm in the New England Journal to be effective in changing practice. Much more effective than a trial showing benefit. When we looked at HFO use across all of the OSCILLATE centers, just a couple of years after the results, it was being used in something like 5% of patients with severe hypoxemia, refractory hypoxemia, before these last results that I showed you were published. In our center, we still use HFO sometimes, but we try to put people in prone before we put them on ECMO, but we don't routinely oscillate them before we put them on ECMO, and sometimes we'd oscillate people that we don't want to put on ECMO. Thank you very much.
Welcome back, everybody. I'd like to introduce the Associate Professor of Otolaryngology, Head and Neck, here at SickKids. He's a staff. And what else do you want to say?
That's all.
That's it.
That's
okay. Good. Welcome. Welcome, Dr. Propst.
Thank you. I was just saying, just Evan is okay. And then so the hardest part is getting the clip onto the tie in the right place. Okay, so thank you. Thank you for having me, Brian. Thank you for this lofty title of the lecture. So the tracheostomy of the future. It sounds very promising, like we have lots and lots to offer, and I hopefully will deliver at the end of the presentation. So I'm going to take you through a few things. First, just some disclaimers and conflicts of interest. I do receive royalties. Our group has written a book on airway reconstruction and how to teach it to our trainees, and so we get some stuff from that. Most of the stuff I talk about is off-label use, So please bear with me for that. And also, there's more than one way to skin a cat, and meaning that everyone has their own way of doing things, and these are just my personal views. And really, there isn't much evidence in surgery in general and in otolaryngology. We don't have randomized trials for things. It's really what is experience and what works the best. So I'm going to give you my take. So we'll go through a very brief history. Each of these will be very brief because I know that I have 15 minutes. We'll talk about how to evaluate the airway, indications for surgery, for tracheotomy, preparation for tracheotomy. What are the steps of the tracheotomy itself? Which trach do you choose and why? Immediate post-op period, some complications that can happen. How do we decannulate and think about decannulation? And tracheostomy of the future, where we're going with all of this. So just to shed some light, they were doing tracheotomies back in 100 BC. Asclepiades of Bithynia was doing them for non-emergent reasons. And this was fantastic. When reading through, I love history of medicine, and reading through, Galen apparently approved, he loved tracheotomy and this idea of it, but Hippocrates favored intubation. And we still have these same debates a few years later. 1909, Chevalier Jackson is basically sort of the hero of pediatric otolaryngology out of Philadelphia. And he basically designed the modern technique of tracheotomy. And really stressed post-operative care. And that's where all the mortality rates dropped. And here is a photograph of him in the back of his limousine. It's actually a video, and he's demonstrating how to perform a tracheotomy on his doll. He was the first person to create a doll for simulation. So it's a pretty fascinating guy. And some people who could have used a trach, George Washington died of a peritonsillar abscess. Dr. Dick was saying, yes, he needs a tracheotomy. They do them in Europe. And the more senior MDs were saying, he's too famous to do a tracheotomy on. We don't want to be responsible. And they only offered the tracheotomy once he was already cold and dead, to which Martha declined. Ulysses S. Grant had a base of tongue squamous cell carcinoma. He could have used a trach as well, but did not get one. And then into the history of using tracheotomy to get you somewhere else. So performing a tracheotomy to be able to do a double-stage open airway reconstruction to be able to get you extubated. Really, that idea was created here at Sick Kids. So Blair Fearon, Robin Cotton, who was my mentor, Blair Fearon I never had the privilege of meeting, and Bill Crysdale, who many of you in the room know. They were the first ones to experiment with all of this and have success. So, evaluating the airway. You guys hear this? How does it make you feel when you see that? A little bit anxious, maybe? Okay, so, what are the things that you think of? The things that I tend to think of are, I just want to know, what is the severity of this child? And to me, it's kind of, there's acute and there's very acute. And acute, they'll have stridor, they'll have tracheal tug, they'll have retractions. Very acute, they're silent. You have to move air to get stridor, right? So they're cyanotic. As soon as the oxygen starts dropping, you know you're into a bit of trouble. As soon as the heart rate starts dropping, you've got just seconds. So these were, you guys were so kind to, in my first week on staff at Sick Kids, if you look next to the pair of scissors, and these are regular scissors, this was the size of the first baby with Treacher Collins in my first week here. And then this is my first night on call. This was what the larynx looked like, the epiglottis. And Toby from anesthesia, he was a fellow there, and I always joke that this got him his job because he shoved a needle into her airway and bought 20 minutes until I could gun down Avenue Road and do a formal tracheotomy. But she was totally fine, aside from a little bit of an elevated CO2, which is a great anesthetic. So if it's acute, then you can take a very brief history, find out if it's infectious or foreign body. Flexible nasopharyngoscopy, move to a safe environment, which we often do. Elude will tell you we often go to the OR where we have anesthesia support. We have bronchoscopes, we have nursing that can help us and such. And if it's very acute, then you really don't have a choice. And it's not always intubation and then think about trach. Sometimes you have to do a trach right off the bat, as was the case with this second patient down here because you can't intubate that larynx. So evaluating the airway, if you have time, flexible nasopharyngoscopy is fantastic. And it doesn't, you're not just shoving it through the nose and quickly getting down to the larynx. I always tell my trainees, enjoy the journey, okay? All of the things from the tip of the nose all the way down to the larynx contribute to airway resistance, and they all are summative, okay? So every one of them should be addressed, and you guys know that because you put in nasal trumpets and all these other things that alleviate airway problems before you go to intubation. And this is the view that we get, and this is anterior view, and this is posterior view, and you guys all intubate so you know what this looks like. And you can do x-rays if you want to find out some more information, and sometimes they're helpful and sometimes they're not. And I usually warn the parents that there's a 50-50 chance that it might help us in any way. That way I don't look as incompetent when it comes back and I say it really did nothing for me. So here we have, you guys know about a thumb sign. Here's the epiglottis coming up here. This is the aryepiglottic fold. This is the arytenoid here. And this is, there's the thumb. And, so we think about epiglottitis for that. Here, if we have unilateral bulging in the subglottis, usually on the left side, we think about subglottic hemangioma. Don't ask why it's on the left side. No one knows. If we see bilateral narrowing steeple sign, if it's acute, we think about croup. If you've waited several weeks, usually 6 weeks we like to wait, and they've recovered from their viral illness and they still have that steeple sign, then we tend to call it subglottic stenosis, but we cannot confirm it unless we've done a rigid bronchoscopy. So these are the pretty pictures that we get when we do a rigid laryngoscopy and bronchoscopy, and we stop at 4 points along the way. This is the supraglottis. You get a nice view. This is with the laryngoscope in the vallecula. And it's a different technique. We don't go under the epiglottis because we want to see the whole picture. So we go along the base of the tongue into the vallecula, a lift up towards the ceiling, and a little flick like this will make the laryngoscope tip. If you're using a Wisconsin blade, it will flick the hyoepiglottic ligament, which actually flips the epiglottis up for you, and you get this beautiful view. So this is a nice close-up view of the glottis. And here's the subglottis, the immediate subglottis. Here's trachealis muscle. Here are the cartilaginous rings. Here's the takeoff into the right main and the left main. You can see the trachealis muscle goes down both sides. And then we evaluate the airway, and we can size it, and we can determine the degree of narrowing. And you'll often see we say, this patient had a grade 3 subglottic stenosis, and that's why we did an open airway surgery for that patient. So into tracheotomy. So why would you do a tracheotomy? The interesting thing, when I was preparing this, I have my reasons. I went on, and we have the reasons that we teach. I went on YouTube just to see what other people teach. And there were videos and trees and diagrams with subheadings and everything about all the different indications. But the truth is you can distill all of that into 3 main categories. And if you can think of any more, tell me. I'll add them. So there's upper airway obstruction. Okay, so that's the one we deal with most of the time. And that can be acute, infectious, foreign body, stuff like that, or it can be chronic. It can be intrinsic to the airway, so inside, within the mucosa, within the lining, within the lumen of the trachea, or it can be extrinsic. It's compressing the airway from outside. It can be actual obstruction that you have to deal with, or it can be prophylactic. So let's say you're doing craniofacial surgery and you foresee that they're going to have breathing trouble. You can do a prophylactic trach. You have no concerns with the post-op period, and then decannulate them afterwards. Prolonged mechanical ventilation. You know all of these. I don't have to go through them. And then pulmonary toilet if their secretions are just so bad that you need to put a trach in to help to clear them. And so here we have a picture, again, this epiglottis that haunts many. And here is bacterial tracheitis, which probably a lot of you haven't seen because we really don't see it all that much anymore. Thank you. So preparing for surgery, there's a new sick kids pathway for tracheotomy. And I'm not going to get into the details, but Peter Lawson and Reshma Amin and Peter Cox, there have been a whole bunch of people, and a lot of the nurses on 5A and in the ICU have been preparing this to streamline the care. And the goal is the ICU initiates the tracheotomy pathway. Otolaryngology comes, and really we just assess for the feasibility. Anatomically, is it doable? And then the ICU speaks with the family, trach teaching starts, everything. Really to get a jump on things, plan the surgery quicker, and try and get people home within 3 weeks. And we've been able to do this. Before this, our average was about 3 months. We had people staying as long as 6 months or a year. And so this is a big hospital initiative. So about the surgery, tips for, so if they're intubated, you want to hyperextend their neck as much as possible. It brings the trachea way out, and then you're not digging in a hole. Unless you recognize this patient who recently came through the ICU. You know, he's multiple fractures, C-spine, unsure about the C-spine, so you can't extend him. So it's a little bit harder to do, but you can still do it. Plan your incision around the C-collar. You never want to put in a trach and then realize you have to put a C-collar back on and doesn't fit through the hole. Skin incision, we make that. I defat the neck. Not everyone does. I find it makes it easier if the trach falls out. There's not as much distance. Other thing is retention sutures. I put in retention sutures right and left. So those are in the sides of the trach. So you can just peel it off the chest and pull left, pull right, and that will just open up the trach. You don't even have to put a tube inside. They'll be able to breathe through their neck if they're not requiring ventilation. Or you can just shove an endotracheal tube in an emergency. I also mature the stoma, so sewing the skin to the edges of the trachea so that so we call it maturing the stoma instead of waiting for it to mature on its own. It's a little bit faster, and not everyone does that. So which trach and why? There are silastic ones, there are metal ones. The metal ones are the older ones. You can get a thinner edge to the tube, and then you can have a wider lumen. So when you get really small, those ones are helpful. Cuffed or cuffless, usually we use cuffed only if they're being ventilated. Single tube is what most of our things are. Inner cannula. In larger kids, it's easier. You don't have to change the whole trach. You could just change the inner cannula. And then the type of ties, they can be twill, or they can be Velcro, or they can be a chain, as some people switch to later on. So immediate post-op period, we don't routinely give antibiotics. Some of you guys may have seen the blue critical airway sheet, and there will be some more formal teaching on this. But basically, when we do the handover, it's just a more formal way to hand over, and then it'll be hanging at the side of the bed. So in case you come and you run to an emergency, you know, you can quickly read it and say, oh, you know, this kid has a stent in their airway. I can't intubate from above, yada, yada. First trach change, usually day 5 to 7, and then we transfer to our ward. So what are some of the complications? Decannulation, false passages, mucus plug. If the trach is plugged and you can't get the plug out, take out the trach. Just take it out. It's fine. Throw in an endotracheal tube, something else. Don't worry about taking out a trach. Even if it's fresh, just take it out. There's no point having a plugged trach in an airway. Bleeding and poor quality of life. Decannulating, I will gloss over very quickly. Basically, the goal is to put a smaller trach tube than normal so that you start being able to cap them so that you can get air up and down. It dries out the secretions, takes away the inflammation. And we can do that by giving Ciprodex nebulized. It's off-label eardrops. And basically, it helps to get around it. So to trach of the future, streamlined pathways, shorter duration of intubation, faster teaching, earlier discharge we talked about, airway database that we're working on, airway M&M rounds that we're going to be starting. We have a special clinic for that, but the key is prevention. And in the last minute that I have, I will go through 5 slides just showing you how important it is to not trach patients. We hate tracheotomies. They cause trouble. If they have a big tongue, you can reduce it. If they have a big tongue in the back, you can reduce it. If they have a mandible that's severely retrognathic, you can advance it. If you have cysts in the base of tongue, like thyroglossal duct cysts, lingual thyroid duct cysts, you can remove them. If you have epiglottic petiole prolapse, you can resuspend the petiole. If the arytenoid is the problem, you can take out an arytenoid. This is a saccular cyst. You can remove it. If they have bilateral vocal cord paralysis, you can put in a posterior rib graft to spread it open. We can put sutures to pull one of the cords over. If you have a laryngeal web, you can cut it out. If you have subglottic hemangioma, you can give propranolol or cut it out. If you have long tracheoesophageal fistula, we can repair it. We can put in rib grafts so the trachealis is not flimsy and flopsy, and you don't need a trach. Subglottic stenosis, grafts. Aortopexy, if the blood vessels are squishing the trachea from the front, we can pexy them anteriorly. If the trachealis muscle is flopping in from the back, you can stitch it posteriorly. And if all else fails, the future, we're working on tracheal replacements. So we've already done this in rabbits, and it works extremely well. We're moving on to porcine model. So we've covered a lot of stuff. We've gone through history, how to evaluate, indications for surgery, and everything all the way to the trach of the future. So I'm sorry, there's a bit of a whirlwind. If you have any questions, I'm open. Yes, Ilud.
So, is there really any downside of traching other than acute bleeding and all that? You trach, you do all those repairs. You have to trach them for most of them anyways, and then you decannulate. Is there a chronic problem at the trach side?
Yes. So most kids who have a trach end up getting granulation tissue. I've had patients where one sibling has pulled out the other sibling's trach and the kid died. Mucus plugs. We've had false passages, tracheonominate fistulas. We've had a patient died in the emerge here of a tracheonominate fistula a few years ago. So all of the things that you read about, they're all real, and trachs they're really bad. I mean, I'm just being honest. If you really need it, then that's fine. But do everything possible in your power to try and prevent putting it in. Most of these things we don't need a trach beforehand. You're right. The open airway surgery. But most of them, you don't need it.
So we're very fortunate in our critical care department. We have some of the best physiotherapists, frankly, worldwide. And representing this very strong group, Ryan Ireland is going to talk about not just physiotherapy, but beyond physiotherapy.
Yeah. That's fine. Go through that. All right. So thank you everyone for having me today to speak at the practical series on respiratory management. Thank you for the introduction. My name is Ryan Ireland. I work in the cardiac critical care unit here at Sick Kids. I've been in the hospital for 6 years and lucky enough to be in the critical care area for about the last 2. I'm up here in front of you today, but I'm speaking on behalf of some of my colleagues as well, Stephanie DeSantos, Jamil Lati, and Emma Pekarski. Really, I feel fortunate to be here today for a number of reasons, and especially following a talk on tracheostomy, where I think that a lot of the things we're going to speak about here today are going to go in line with maybe some of the management options and techniques that were spoken about. I also feel fortunate enough to be here today because I get to dress up for a day, and I was thrown up on 3 times last week. So this is a welcome change for me. So moving on, no disclosures, nothing to report. We're here today really to go over a few objectives, the first of which is to review current PT management goals in the ICU setting. We're going to highlight some reasons for impaired ventilation and their clinical manifestations at the bedside. We'll then review the consequences of prolonged mechanical ventilation and highlight some PT strategies that are implemented to foster early mobility in the ICU, as well as introducing some respiratory muscle strengthening therapies, and as well as looking at the future direction. So where do we go from here? In terms of goals of physiotherapy in the ICU, really we're looking at implementing safe mobilization practices, optimizing positioning for things such as joint preservation, skin integrity, and ventilation perfusion matching. We also want to provide opportunities for age-appropriate development, as well as increasing independent functioning. We look to increase overall strength and activity tolerance, as well as optimize pulmonary hygiene to ensure adequate ventilation. So this next slide here talks about cardiopulmonary physiotherapy, and really what we're looking to do is outline techniques that are often referred to as the so-called traditional chest PT, okay? So these are often prescribed techniques for those individuals who present with collapses, consolidations, who may not necessarily have compromised airways at baseline. Okay. These can be very quick and effective ways to restore ventilation to the areas which are most affected. So really here when we're talking about the types of patients that we might be following, and we're going to make this brief just because we're looking at beyond chest PT, but for our ventilated patients, you guys are probably familiar with techniques such as manual hyperinflation with expiratory vibrations, also known as the bag and vibe, as well as some lung recruitment maneuvers. For our non-ventilated patients, including the non-invasive population, we have individualized treatments containing usually one, if not a combination of some of the techniques we see here. So manual percussions, expiratory vibrations, rib springing, basal lifts, and might be more active treatments such as PEP devices, incentive spirometry, deep breathing. Okay? There's also a contributory role of PT in combination with the RTs for the cough assist. Really, the components that are described here are exactly that. They are components of a much larger field of cardiopulmonary physiotherapy. So when we think about chest PT, we want to think about that as being only one component that's involved in the effect of a much larger area of therapies. In terms of impaired ventilation, so manual techniques only represent a portion of our pulmonary treatment because the reasons for impaired ventilation are not always directly related to secretion retention or atelectasis. As you all know, there's a number of anatomical and physiological factors which have a detrimental impact on ventilation, which may require additional therapies. So we've outlined here on the slide some impaired ventilation reasons. In no particular order, airway abnormalities, suboptimal chest wall expansion due to maybe rigidity, scarring, or poor thoracic muscular strength. We might have issues with the diaphragm, including paresis, paralysis, or herniation. There may be an inflammatory disease or response, neuromuscular conditions, which we're well aware of, as well as some issues with impedance to airflow. So whether that be obstructive in terms of secretions or scarring, or more resistive or restrictive in terms of bronchospasms and airway narrowing. Even secretion retention itself is multifactorial in its cause. Cardiopulmonary PT aims to effectively assist in secretion management, but also to better explain why this patient may be having difficulty mobilizing these secretions in the first place. As well, we look to provide therapies that enable this patient to more independently manage their secretions and ventilation. So we may have increased secretions due to obviously a viral bacterial cause, namely a pneumonia. It may be increased viscosity, some humidification issues. We could have inadequate ciliary motility, whether that was pre-existing or ventilator-induced. And really what I'd like to focus on is the last 2 points, is being weak respiratory musculature, which can affect the cough, as well as immobility or poor chest wall expansion. Just to make a little note on sedation there with the weak respiratory musculature, we see in a lot of our population who are sedated and or muscle relaxed, this is going to have a clear effect on the inability or absent cough. And this is going to have a profound effect on someone's ability to manage their own secretions. This may be an indication for those chest therapy techniques to help and assist with mobilization of secretions, but also we want to think about how do we tackle the issue of more chronic populations in terms of respiratory musculature weakness. So some clinical manifestations that we may see at the bedside. These are just things specifically on observation that might be easily foreseen for patients who are ventilated here in the hospital. We see things such as poor posture, whether that be kyphotic or that cachectic appearance, weak and effective cough, inefficient chest wall mechanics, insufficient contraction of the accessory muscles of respiration, as well as that rapid rate of increased work of breathing at our attempts of weaning from the ventilation. We normally see that the longer someone is on the ventilation, the more rapid you'll see these changes when we try to either perform spontaneous breathing trials and or extubate. In terms of this diagram here, we're really just looking to narrow in on the population that we want to speak of today. We have our ventilated patients who, for the argument's sake here, the literature defines long-term ventilation as any 7 consecutive days of ventilation, whether that be invasive or non-invasive. So if someone's extubated from days 1 through 6, we're going to leave those for another talk. Today we're going to focus on the long-term ventilation, which are those who are 7 days or longer. Generally, when we see referrals for these populations, we're looking at one of 2 avenues. It's either respiratory management or mobilization and deconditioning. We can further break apart respiratory management in terms of secretion clearance, collapse consolidation management, and or increasing respiratory muscular function. And that's what we'd like to focus on here. So this has a very closely related tie to mobilization and conditioning, because really we're looking at using these mobilization techniques to help increase our respiratory functional strength and the musculature involved in respiration. Now, this again leaves us into thinking of 2 separate schools of thought in terms of management of long-term ventilated patients, where on one hand we have the ability to potentially perform tracheostomies to allow for increased rehabilitation to help resolve the issues of weakness in the muscles of respiration. And then we have the other side of things where we know that not a lot of our parents are interested in doing tracheostomies, nor are a lot of physicians, for obvious reasons that were just pointed out in the previous talk. But there are different ways with using prolonged ventilation and weaning strategies on the vent, which we can also try to increase respiratory muscular strength. So it isn't news, really, that that we have very, very complex patients as a result of great frontline medicine that are living through disease processes that many years ago were considered to be death sentences. This places an unrelenting burden on the costs of healthcare and is likely an explanation for the increasing ICU-acquired comorbidities, including ICU-acquired weakness. So for here, we're talking about long-term ventilation, which causes muscular atrophy, which is strongly correlated with both peripheral or limb muscular strength as well as respiratory muscle weakness. Okay? We know that with this atrophy comes increasing difficulty to wean from the ventilator, and we know that increased days on ventilator can result in an increased risk of things such as ventilator-acquired pneumonias, bed sores, DVTs, all those things that are associated with poor mobility, as well as increased length of stay in the ICU and hospital, which equals dollars. Evidence suggests that it's beneficial to initiate early rehab and mobility in populations who are chronically ventilated for improved quality of life, meaning earlier movement out of bed leading to quicker return to functional independence, as well as reduced incidence or duration of things such as delirium, which we know is a very large issue. Our top priority would always be to try to extubate our patients as quickly and as safely as possible, but experience tells us that there's a growing population in which this is maybe not as easily feasible as we may think. Again, we need to decide which strategy, whether it's tracheostomy or otherwise, and how we're going to approach strengthening the muscles of respiration. This is just a nice slide here that's it's related to immobilization and the burden of severe critical illness, but we know that with long-term ventilation comes a lot of issues with immobilization, something that we are trying to actively remedy. But really I want to draw your attention to the areas under the burden of severe critical illness at the bottom, things like post-traumatic stress disorder, anxiety, delirium, as well as caregiver burnout, things that we hear a lot about in our chronic long-term ventilated patients, not only from the patient perspective, but also from the staff. What we're really hoping for is a holistic approach. We're very large proponents in patient-centered care and family-centered medicine, and although we might be seeing a patient for a respiratory concern, we need to keep in mind that there's also MSK and neurological consequences. So what we'd like to do is find that sweet spot in the management of all three of these categories in which physiotherapy specifically focuses in the ICU to ensure that we are not only maybe concurrently treating all three of these areas, but we are mindful of how limitations in something, let's say, a neurological component of a patient may limit their ability to take part in certain respiratory exercises. Okay? So a perfect example would be a trauma patient who may be at risk of MSK, neurological, and respiratory issues, and how all three of those are going to affect your choices for possible treatment. The pros of this approach really is that each child gets what they need, so that patient-centered approach, but the con is that it's very hard to standardize in terms of research. If everybody is getting different treatments, it makes it much more difficult to monitor and measure the impact in these complex populations. So in terms of strategies which have already been implemented to improve care in terms of respiratory and other management, really we're looking at things like early mobilization. So automatic referrals are being put in place for a complex patient population such as ECMO, MSK traumas, brain injuries, strokes, burns, and this allows us to be thinking day one about the impact of mobility and how we can help support respiration. We also have the use of physiotherapy assistant, which can provide assistance in range of motion, strength and mobility programs, which are all tasks that are delegated from the primary therapist. We also have a seating partnership with Holland Bloorview, where we have a staff member who is shared role in both centers who can help us really set up patients with customizable early mobility seating devices on day one. Okay? This also is going to help us improve transfer readiness to go from center to center in terms of continuing rehab. In terms of respiratory muscle strengthening, it's not to be confused with respiratory muscle training that we see in COPD populations with the oral devices of resistance, but really we're looking at currently what is a non-standardized practice. There's no protocol associated with what we're doing with these populations, but really it's something designed to increase the strength and endurance of the thoracic musculature with the goals of providing improved chest wall expansion and mechanics, improved cough, posture, mobilization, and activity reserve. This is meant to augment quicker respiratory recovery through improved secretion clearance and increased respiratory muscular strength to allow more successful attempts at weaning. In infant populations, this looks a little different than adult populations. In infants, it's more development driven. We're looking at weight-bearing activities, really increasing central tone, using different positions and mobilization techniques to strengthen the central musculature of the trunk, where in older populations, it's really functional driven. Can we utilize the upper extremity and the strengthening and the mobility of the upper extremity to help mobilize the chest wall and again to help increase their functional independence and add to their, hopefully, quality of life. This slide here just outlines how respiratory muscle weakness can be the center of a lot of different issues that we're seeing in our chronically ventilated populations here at Sick Kids. We know that it's important to strengthen these muscles because they are so central. We know that atrophy in our muscles can take only days, where building back up of the strength in these muscles can take weeks to months. So it's important that it's something that we look at early on. In terms of future research, really, as always, we need more clinical studies in pediatrics. Most of any of the information that's out there is based on adults. What we really would like to do is determine, is there a role for respiratory muscle strengthening, and what is its impact on long-term populations in pediatrics? Is there a protocol or a standard outline of care that we can follow or develop? How do we quantify atrophy or weakness? And how do we measure the change pre- and post-intervention? Is there a role for a technology or a use of an outcome measure that could potentially be used at the bedside in these populations? Our limitations in the current research relate to really that lack of standardized approach, so as we talked about in terms of patient-centered care, as well as having inter-therapist variability in the way things are done at the bedside. All these things contribute to a lack of standardization. We know that with standardization we get increased efficacy, which can help us specify which outcomes have a direct impact on care. These are just a couple studies here that I'm going to touch on quickly. The first one on the left is talking about the CPACS assessment tool. So that's the Chelsea Physical Assessment Tool, developed in England. It's really a standard assessment tool to determine at-risk populations for ICU-acquired weakness. A currently, a group from Brisbane is actually looking at modifying this tool and making it more pediatric friendly. So this is something that, again, might be helpful in identifying who's at risk at the bedside. And on the right, you're going to take a look at recommendations from Karen Chung and her group on the effects of early mobilization in critically ill children and the benefit that that can have in our populations. We were lucky enough to have Karen here for a talk last week where we discussed rehabilitation bundles at the bedside and what that might look like. So really what we need to do is continue to collaborate with our physicians and our interprofessional team. Together, we can determine what our priorities are as a critical care center. There's value in determining what existing research is being done, not only within our center, but in our other centers which we benchmark ourselves against in terms of pediatrics, to see if we want to align with these centers in their existing research or initiate therapies of our own and take a look at what types of things could be useful in these populations. So we're hoping that this is not, a small few people of interest who can drive a change, but really looking at buy-in from a more larger scale potential, because the only way these initiatives have staying power is if it's sort of that change of culture that people truly believe in the change, and that's the only way it will keep going. So in summary, thank you guys very much for having me here speaking on behalf of my colleagues, and we'll take any questions.
Thank you very much indeed, Ryan. Any questions, please? Anne-Marie. I can repeat the question.
You're welcome.
When you say identify patients at risk, if there was no financial or resource, limitation, would you advocate that all children need a certain amount of PT, or is it really sort of only the ones? How do you define risk, like the ones that are most likely to benefit because they're just so much more far gone? My impression is that we want to try to tackle the problem before it gets to that. Or what have things changed in the last 10 years? What's your thought?
Yeah, I think so. Identifying the patients who are potentially at risk, I think we know that with any type of ventilation, there's going to be risk for things such as what was talked about earlier in the table, lots of issues, not only physical, but the cognitive impairments that go along with that, whether that be 1 day of ventilation or 3 months of ventilation. I think as you were pointing out that if resources were not an option, I think that really the role is there for improvement for bedside care, whether that be through physiotherapy, nursing, RTs, anything really for ventilated patients. And it starts with something from a basic sort of ground level approach. So it's how we position our patients who are ventilated. It's how we mobilize the positions that are ventilated. If that means that it's done through physiotherapy practices, we would love to support those initiatives. But I think it truly is much more than just having therapies at the bedside, but again, thinking larger scale, thinking about sort of almost like a checklist approach as to we have a patient who's ventilated, we need to be doing X, Y, and Z, no matter how long we expect them to be ventilated for. It should just be what's considered sort of best practice, and that's what we're trying to change in our units.
Great. Ryan, Ireland, you have to love that name, right? But here's a very large check, and thank you very much indeed.
Thank you very much. Thank you.
While we're changing over here, we have had a long and very sort of world-class tradition, really, of trainees who have excelled in pulmonary or cardiopulmonary research. The list is long and eminent, from Des Bone, Peter Cox, Margaret Schindler, Katsuya Miyasaka, a variety of people, and we have two no less today. The first is Takeshi Yoshida, who is really a world expert in pleural pressure measurement and how the pleural pressure is affected by posture, by spontaneous effort, and how that causes or protects against lung injury. He's going to describe a small snippet of some of his very, very cool work. Takeshi, thank you very much.
Thank you so much for a kind introduction. Just wait a second. Oh.
Here we go.
Okay. It's only once.
There we
okay.
go.
Okay. Good morning, colleagues, and thank you for having me in the 50th anniversary today at the SICKIS. So today I'm going to talking about a new concept of lung recruitment, which is continuous negative abdominal pressure in ARDS. So let's go back to the 70s. And there was a distinguished physician here at SICKIS whose name is Professor Charles Bryan. And he published so many brilliant papers. And this is one of my favorite. In this paper, he mentioned that the abdominal pressure is an important factor for the dorsal atelectasis and therefore a dorsal hyperventilation. So he clearly mentioned this important concept of abdominal pressure back in 70s. And then after almost 50 years have passed, this important concept, which is abdominal pressure is an important factor for dorsal atelectasis, is now widely accepted among physicians. So when the abdominal pressure is increased, this pressure is transmitted in the thorax through the diaphragm, compressing dependent part of the lung and causing a lot of lung collapse, especially in the dependent part of the lung. And usually we treat this with PEEP, but unfortunately PEEP preferentially inflate the already aerated lung regions before starting dorsal lung recruitment. So in this study, we hypothesized that if we could decrease abdominal pressure, we can decrease the amount of atelectasis, and then we can reduce lung injury. And we achieve this with this device. So this is a simple prototype of CNAP device to decrease abdominal pressure by -5 centimeter water. And this is one of the most important findings. So this shows the impact of decreasing PEEP on the oxygenation with or without CNAP. So the y-axis is the oxygenation, and the x-axis is a wide range of PEEP from 20 to 4 centimeter water. So this is without CNAP. As you see, lower values of PEEP result in lower oxygenation, which is as expected. But when CNAP is present, or I would say when the abdominal pressure is decreased, much better oxygenation was observed at most level of PEEP. And then we also plotted the oxygenation data against the transpulmonary pressure, but not the PEEP. And please note, the transpulmonary pressure is the real lung distending pressure. So again, lower values of transpulmonary pressure result in lower oxygenation linearly, so that now the slope is quite steep. When the CNAP is present, much better oxygenation was observed at the same transpulmonary pressure. For instance, at the transpulmonary pressure of -5 centimeter water, the oxygenation was very low, which is around only 100 mmHg without CNAP. But when we can decrease abdominal pressure at the same transpulmonary pressure of -5 centimeter water, now the oxygenation was far better, which is around 300 mmHg. So the next, we are now looking at the distribution of ventilation with or without CNAP. So these EIT images were obtained without CNAP. So as you see, most of ventilation is now shifted in the non-dependent part of the lung. It's because we have a lot of lung collapse in the dependent part of the lung. It's because this is ARDS model. And then these EIT images were obtained with CNAP. So when we decrease abdominal pressures, we can achieve much better, more homogeneous ventilation during mechanical ventilation. And please note, both images were obtained with same tidal volume and also the same transpulmonary pressure. So the oxygenation data and also this ventilation data clearly shows that the impact of CNAP on the lung recruitment is not the same as simply adding more PEEP. So the mechanism for the lung recruitment is totally different. And then we took 2 CAT scans with or without CNAP. So the first, these CT images were obtained without CNAP. So as you see, there are a lot of lung collapse, especially in the dependent part of the lung. And then we decreased abdominal pressure by applying CNAP. So now we observe 2 things here. The first, CNAP can recruit dorsal atelectasis by decreasing abdominal pressure. And then the second, CNAP can prevent the cranial shift of the diaphragm. So CNAP can maintain the diaphragm upright position, and therefore CNAP can eliminate the abdominal pressure superimposed on dependent part of the lung. In this way, CNAP can recruit selectively dorsal atelectasis. So this is how CNAP works for the lung recruitment. And then we wanted to evaluate if CNAP could reduce lung injury or not. So we randomized the pigs into 2 groups, with or without CNAP, and then ventilated for 4 hours. So this is a gross appearance after 4 hours of mechanical ventilation without CNAP. Okay? So as you see, there was a very, very severe lung injury. In contrast, this is a gross appearance after 4 hours of mechanical ventilation with CNAP. So obviously, the lung injury was much less. And we show this just for the visual impacts, but the impacts on the measurement of lung edema are also similar. So this is wet-to-dry ratio, and as we know, the wet-to-dry is a good surrogate for lung edema, and wet-dry was significantly lower with CNAP. And the next, now we are looking at the IL-6 in lung tissue, and IL-6 is a key pro-inflammatory mediator in ARDS. And IL-6 was significantly lower with CNAP. So this is our conclusion. CNAP can selectively recluse dorsal atelectasis by decreasing abdominal pressure, improve oxygenation, and achieve more homogeneous ventilation. And then CNAP can reduce lung injury. Thank you so much.
Takesh, thank you very much indeed. We'll take a presentation from Bhushan, and Bhushan's area of focus, gets dropped up there, is on heart-lung interactions in ventilator-induced lung injury. And then we'll have a few minutes for questions for both. Thank you very much, Takesh. Thank you, Bhushan.
Thank you, Brian. What I'm going to go through over the next few slides is to look at the other side of the alveolar capillary membrane, and where the convention believes that ventilator-induced lung injury is primarily an alveolar process and hemodynamics are merely a secondary consequence. I try to make a case against it by presenting 2 different projects. First is about injurious heart-lung interactions in VILI, and second is a newer term of VILI which we call as deflation injury. Can heart-lung interactions contribute or cause ventilator-induced lung injury? In a recent publication, we suggest that it does. What we have essentially done is repeated an old study which was published back in 1974 by Webb and Turney, a slide which Dr. Cox showed earlier. We could show again, as they had shown, that if a rat is ventilated at pressures of 45/10, the lungs look edematous, but they are not badly injured. However, you take the PEEP away and ventilate them on 45/0, the lungs are significantly injured. Associated with this, while looking at their echo and pulmonary perfusion, we see that at 45/10, the pulmonary perfusion is intermittently reduced, appropriately along with tidal ventilation. However, with 45/0, the pulmonary perfusion is completely interrupted or stopped, and the changes of perfusion are larger. Why does this happen? Is it because the capillaries are compressed? No. If you look at the real-time echo, in 45/10, the ventricular volumes reduce with each inspiration. But in 45/0, with each inspiration, the RV is completely smooshed, and there is no forward flow. So this on-off flow that we saw on the pulmonary perfusion is actually because of absent preload and not afterload. This kind of injurious ventilation results in progressive RV failure with increasing RV size and reducing RV function. So we have on-off flow, we have lung injury, and we have RV failure. This on-off flow mechanism we postulate will cause endothelial injury, which has been shown in the same models to be present before the alveolar injury. So endothelium injury actually precedes alveolar injury in the same models. In systemic circulation, such on-off flow is also been shown to cause significant endothelial injury. So we make a case that it is endothelium which is the cell of initiation and propagation of ventilator-induced lung injury. Moving on to the newer form of VILI that we call as lung deflation injury. In a serendipitous observation, we saw that when healthy rats were subjected to high PEEP and they were suddenly removed, they died of hemorrhagic edema, which was pretty rapid. Why does this happen? Well, we studied this more carefully. If you look at the control animal who's ventilated 10/3, this is a normal lung. An animal who was subjected to high airway pressure and abruptly released showed significant lung injury, poor oxygenation, poor compliance, and increasing edema. Is this because of high airway pressure, or is it because of abrupt release? I'll make the second case. Looking at ultrastructure, this is a normal alveoli. Just before deflation, which is on high PEEP, there is mild edema. But within 5 minutes after deflation, there is significant alveolar edema, and RBCs are seen in the alveolar sac with reduction in alveolar volume. Endothelium, this is a normal endothelium. Before deflation, at PEEP of 11 or 12 centimeters, there is mild edema. But within 5 minutes of deflation, there is endothelial injury, interendothelial leak, and we can see WBCs coming and sticking onto the endothelium. This causes microvascular leak and injury. The hemodynamic consequence here, we can see in the real-time echoes. And PEEP of 3, this is a normal echo. On PEEP of 11, both of the ventricular sizes are reduced, but their relations are normal. Right at the time of deflation, the heart is hyperdynamic. The right ventricle is much more dilated than the left. And within 30 minutes, the heart is slower, the right ventricle is more dilated, and it's like the animal is going to die. Why does this happen? Why does the RV go into acute failure? Where does this increased pulmonary vascular resistance come from? It actually comes from systemic circulation or from the left ventricle. We can see here a real-time record where a sudden release in airway pressure led to an abrupt increase in arterial pressure, but also led to a significant increase in left ventricular end diastolic pressure, which we think is because of two reasons. A significantly increased LV preload, and because there is an increased vascular resistance while increasing PEEP, which is kind of mismatched, the total load on the left ventricle increases. This, what we've seen, has gone from almost 8 millimeters of mercury to as high as 30-35, which is in the range of capillary stress failure, would cause back pressure, capillary injury, and now we can connect the dots, and therefore abrupt lung deflation will cause significant lung injury, as we can see in this picture here. If these animals were treated with sodium nitroprusside, that is, if we reduced the afterload, the lung injury was abated. So it kind of proves the point there. Why is this important? This is important because, as we have seen earlier, the HFO, the recently published ART trial, and many other PEEP trials have been negative or have shown minimal benefit. This may be because this hidden form of injury, which is related to sudden airway pressure release, might have been missed, and probably contributing to ongoing injury and trying to negate the impact of beneficial effects of high airway pressure. It could also explain some of the reasons why extubation failure takes place. We should look back at its suction practices in some situations. And in other clinical scenarios where the lungs are injured, the LV is injured, or there is increased systemic afterload, this might have a significant impact in clinical care. So although alveolar processes are primary to VILI and hemodynamics are believed to be secondary, I actually make a case against. I think that it is endothelium where the injury starts, and heart-lung interactions, systemic circulation also contributes to the formation of lung injury. Thank you.
We'll take questions now for Takeshi or for Bhushan.
Excellent. Thank you. Same to you.
Good.
First to Takeshi, but kind of overlaps.
Okay.
So you have negative pressure in the abdominal compartment, and arguably, although I don't really know whether I'm right or not, high PEEP is hemodynamically deleterious because you got away preload,
does that not happen in your CNAP procedure?
So what's the trade-off of negative pressure in the abdomen and positive pressure in the airway on cardiac preload?
Actually, it happens really when we apply the CNAP at the first moment. So when we apply the CNAP, the preload go back to the heart is decreased, so that we often observed the hemodynamics is a little bit unstable. But what is interesting is that we ventilated for several hours. The end of the experiment, actually the cardiac output and also the hemodynamics is better in a CNAP. And I think it's because we can spare the higher mean airway pressure or the higher PEEP. So I think this is one of the reasons.
So you didn't volume load at this point?
No, first we did. Yeah.
Anne-Marie?
How different is this pressure applied to the abdomen than the back dressing that we can apply after abdominal surgery in terms of how you set it?
So a pressure around the abdomen versus the pressure applied to the top of the abdomen.
I don't know the right answer to these questions, but if we can decrease the abdominal pressure by using this back dressing, and then if we measure the gastric pressure or the bladder pressure, and then you observe the negative abdominal pressure, maybe the effect is similar, but we are not sure. Yeah.
What about other devices that have applied negative pressure on top of, but not around the abdomen?
Yeah. So actually, when we look back the previous literatures, actually there are several papers to test this hypothesis, but they usually use the different device just covering on the top of the abdomen, and then they fail. It's because when we look at the gastric pressure, they never reaches the negative abdominal pressure. So maybe this is the reason for why they fail.
Dr. Bowen.
So, Bushan, I was very intrigued with your demonstration of the effect of ventilation on RP function. And I think it's probably analogous in congenital heart disease when you see restrictive right ventricular physiology in the setting of tetralogy of Fallot, where with their very sick ventricles, you can demonstrate that during positive pressure, you almost obliterate flow across the pulmonary valve. And I would imagine that's an analogous situation to the one you demonstrated.
Yeah, I cannot agree less. Perfect. Thank you.
For God's sake, don't disagree. let's just get that clear.
Yeah, yes.
Maybe Anne-Marie or Elizabeth. Any other questions? Anne-Marie.
When you showed us those electron micrograph pictures, how can you tell me that it's not just, I call it stretched and then not stretched tissue, but truly more, I guess, water you're claiming is in that tissue?
Right. So all of them were treated at the same filling pressure of the glutaraldehyde. So an animal was ventilated. We went up to PEEP of 11, sacrificed the animal. The lung was deflated and reinflated with glutaraldehyde. The second animal, where animal was ventilated, high PEEP, the PEEP was released. The animal was sacrificed in 5 minutes. Because the lungs were deflated, the airway pressure was disconnected, so there's no ventilation, and then reinflated with the same 10 centimeters of pressure of glutaraldehyde. So they were treated similarly. So the differences that we see are real rather than treatment.
Jason.
One of your slides in relation to the cyclodecent pressure, you talked about maybe looking at our suction practices. What were you getting at?
So what are the implications for suctioning practices?
Right. So as we saw that abrupt release within seconds elevates left ventricular and diastolic pressure. So it's not minutes, it's seconds. So it can be deleterious. Whether closed suctioning is the right thing to do, the trade-off is small tubes, blockage, circumferential block. So we need to, it's not a clear indication that we should always not do open suction, it should be always a closed suction. Second part is, where there is an abrupt release, we also add negative pressure, whether that also causes increased atelectasis and therefore more microvascular flow and microvascular injury, that is yet to be known.
So Bhushan, you think that this phenomenon occurs because you get a sudden surge forward of flow and into a pre-constricted compensatory constriction in the systemic circuit. What kind of patients, if this is borne out, what kind of patients would be at highest risk?
So those who are on high airway pressure, those who have pre-injured lungs, those who have a failing LV, and those who are on high vasopressors, I would be cautious. What we have shown, which I didn't show it here, was if you reduce the airway pressure gradually, this injury is also abated. So therefore, the forward flow and the relaxation of vascular resistance probably matches each other, and you don't get an increase in left ventricular and diastolic pressure. So in those situations, suctioning could be made carefully by slowly reducing the airway pressure, do a suction quick, and then go back on that airway pressure.
An excellent question was just asked. I think, are you doing any work around the techniques that we might use, or you're aware of any work that looks at this in more detail, because it seems a very important clinical effect or potential clinical effect that, as you say, occurs in seconds. I think we get a sense at the bedside that the sick patients don't like being messed with at times of suctioning. We have additional personnel, we have pre-medications and things. So if you would, are there more things you think you would want to know or understand before recommending changes of practice?
Well, that's absolutely important. The next plan to do is to see whether this is just not a rat phenomena, that it occurs in bigger species, rabbits or pigs. If we can get a human signal, there is some studies, especially from adult cardiac ICU, where sudden releases in airway pressure in a sicker left ventricle did cause weaning pulmonary edema or extubation pulmonary edema, which is conceptually similar, but it's mechanistically a bit different, where the transmural pressure in the left ventricle is suddenly changed against here, where I'm demonstrating that it's the load on the left ventricle, the preload and the afterload, which are different. So there would be a reason to see whether this signal we get in humans, especially with lung injury, especially with sicker left ventricle. We could study them using cardiac output monitors or PICO, measure the afterload, see the changes in the left ventricular load during suctioning or during airway pressure release. If we get that signal, then we can make a stronger recommendation that yes, we need to change practice.
Bhushan, it's single species. It's not rat data. It's single species. Takesh and Bhushan, thank you both very, very much indeed for all the work that you've done and for explaining it so clearly to all of us. Thank you both. Very, very large check.
Thank you.
Nobody can see.
So to conclude our morning session, please join me in welcoming Dr. Anne-Marie Guerguerian and Dr. Gail Annich, both of whom have extensive experience using ECLS for patients with lung injury.
Yeah. Okay. Clip.
Do you have a pocket?
No. We'll figure it out. Okay. Oh. Okay.
Okay.
Can you hear me? Bonjour. Okay. Disclosures, no financial. We both volunteer for organizations, and Gail volunteers for the Extracorporeal Life Support Organization, which is a founding, essentially, organization to support patients with lung injury. So just some nomenclature and regulatory aspects, because we do use devices under Special Access Program from the Health Canada group. The extracorporeal life support is the term we use to encompass different types of devices, extracorporeal membrane oxygenation, and we use different types of devices at Sick Kids. Interventional lung assist ventilator, which is the
device that is approved as a ventilator in Canada, and ECOR. So ICU care with ECLS is about decision making. And here we have Dr. Bone in the audience. We're very lucky. So in 1991, the program started after the program in Michigan. And already Des was reporting in the Toronto Star about the case and how we needed more resources back then. After 3, I believe, he went straight to the media. And this was the beginning. But essentially in 1990, there were 3 questions about VA ECMO for respiratory failure, and this is from Peter Cox's archives. Is the respiratory failure despite maximum pulmonary support? Is it respiratory failure potentially reversible? And is death imminent without bypass? Not many things have changed, but we've added a couple of considerations. So in 2018, when we consider ECLS for lung failure, we ask, what is the need? Does the patient have cardiopulmonary or pulmonary failure? Is it reversible, which is similar to what was being asked? Is it reversible within a reasonable amount of time, which will bring Dr. Annich to talk about how we care for the patient on ECLS with lung failure? And if not reversible with recovery, is organ replacement by transplantation an option that I may talk about if we still have time at the end? So it's about offering support to either bridge therapy or recovery, bridge to decision and palliative care, bridge to organ replacement. And currently, both in Canada and the US, there's no destination therapy with extracorporeal life support for lung failure. The main modes are VA ECMO and VV ECMO, and we'll mention ILA if we have time. So why do I mention the need? Because people will often say, oh, Amory, what do we use or what will we connect? And then I stand back and I tell the fellow, well, what does your patient actually need? What is the mode of failure? And whether it's respiratory failure, we'll use VA or VV ECMO. If it's cardiopulmonary failure, it'll be probably VA ECMO, and there's submodes. And if it's respiratory failure with pulmonary hypertension and RV failure, it'll be interventional lung assist device ventilator. Keeping it simple. And if we dig down into respiratory failure, well, it's true that if it's pneumonia or sepsis, we potentially will have different consideration whether or not we have pulmonary hypertension with ventricular failure. And if there's end-stage lung disease transplantation, other things come up. We don't have time to talk about its uses for complex tracheal bronchial surgery, but we know that it is used for that indication. And also it's potentially an elegant device for temporary use during pulmonary embolism. So ultimately, we've got big categories of utilization: VA ECMO, VV ECMO, ECOR rarely. And I'll call out to one of our fellows, why do we rarely use ECOR in children? Before I pick on a fellow, Pompa. I know. And you thought I couldn't see above all the heads over there. Because hypercapnic respiratory failure is actually a rare disease in children. It's not because we're not necessarily high users. And ILA. And so it's really about whether or not you think the device in the system will provide either like 80 to 150% of the support for VA ECMO versus 50 to 80 versus 20%, and it would be rare in children that these diseases occur. So most of you here are familiar with the system, and it's different membranes with, in our organization, a centrifugal pump. And the key determinants are actually thinking back to what the patient still has as a function, both for the native heart and circulation and through the lungs, and what the system can offer. Exchange of oxygen is really one of the mainstay in the functions that we use it for, and it's dependent on the FiO2, on the inlet SVO2, the membrane's capacity, and I would say in contemporary time, membrane's capacities are extraordinarily good, so it's rarely a modifier. Red cell exposure and blood flow. Carbon dioxide is really sort of regulated by the gas flow rate and independent from the blood flow. And as I said, the membranes are very efficient. Cannulation in children is one of the main variables that limits our ability to expand potentially this technology when we want it to very broad ranges of sizes and ages. And I'm just going to, go back to the main system just to highlight the difference between a system that has a pump and an oxygenator. And we've added different, I would say, connectors to be able to add a hemofilter or to measure pressures pre and post and to measure the integrity of the membrane. And we've got the simple system that only involves what we call the interventional lung assist ventilator, which is essentially just a membrane that connects between the pulmonary artery and the pulmonary veins. So essentially from the right to the left. So a couple of cases, and I will ask, because this is an intro to the afternoon of interaction that you will be having. So you've got a patient with persistent pulmonary hypertension, and you're called from the NICU who's 36 weeks, 2.5 kilos, day 3 with worsening hypoxemia despite HFO, INO, shock, epi, dopamine, vasopressin, before calling Takeshi for the CNAP, because I don't know if they have a very small one yet. They do a cardiac echo, and they show bilateral decreased ventricular function, PDA, and dilated RV. So what's the purpose of this support? ELOD, bridge to decision, bridge to recovery, bridge to transplant, or bridge to palliation.
2.5 kilos.
Recovery? Do you disagree?
I don't think I have the experience.
He has the most gray hair, but he's most reflective. So, what mode and configuration? If you've made a decision on this side, VA neck. Okay, so B. So the purpose is the first thing, bridge yes to recovery and or decision, because your point about the 2.5 kilo was correct. One needs to ask oneself, potentially. Hypoxemia, the indication is hypoxemia with cardiopulmonary failure. We'll initiate with a goal to wean off within 7 days. And at sick kids, we'll do a lung biopsy within 7 days. And we'll use, yes, veno-arterial neck cannulation. And we base that, and this was a practice that was being done, I would say, over the decades. And last year, with Aidan Moore in the neonatology and one of her fellows, we asked the questions, how many times were we actually hitting it properly to potentially do a biopsy at 7 days and uncover essentially a lethal disease, unless there was transplantation. And I would say between 2003 and 2015, and this is in PPHN without any other abnormalities like congenital diaphragmatic hernia, if you look down through number of subjects ultimately, so that's many, many years. So the majority of the infants, as you see, are treated with HFO at 673, and 27 subjects were referred for ECMO. 15 were put on ECMO, and 12 were put on no ECMO. And among the patients who were put on ECMO, we uncovered essentially sort of a fatal condition with what we call alveolar capillary dysplasia in 6 of the 7, and in the other one that was essentially sort of an abnormality of surfactant. And the other group survived. So in neonates with PPHN who are term at sick kids, it's true that we use ECMO seldomly, but we seem to use it in circumstances that are reasonable and do biopsies in timely fashion. CDH, 38-week, 3.4 kilos. Des, cover your ears. Prenatal consultation. Lung-head ratio favorable, hypoxemia, despite HFOV, has a ballooning RV. Bhushan. What's your purpose? Anybody else think differently? So we've got A, B, and C, which probably actually reflects what people do across the world. Des, yes. So purpose is, yes, Des's choice. Bridge to, call me back later, would be Des's. Bridge to recovery and optimized medical therapy. Hypoxemia and hypercapnia with cardiopulmonary failure is, I would say, the main indication. And usually the goal is to wean off between 3 or 4 weeks, and in our organization, we repair off ECMO. Pneumonia and ARDS, 9-year-old, this is probably currently the 60% of the patients that we support with respiratory failure at Sick Kids are similar to this patient. Pneumonia, they've got strep A, or they have a virus, they've been a week on mechanical ventilation and HFO, and we get a call because they've got pneumothorax and they're quite hypoxemic. How do you cannulate them, Georgia? I guess because we transportable, yes, so she's local, so yes. I would say that would be our first choice now with this, so bicaval cannula, like I said, patient 1 and 2. And if we had to retrieve with the AXE team, we would probably not choose that mode just because it's more difficult to support with remotely to insert those catheters. And we would use femoral artery and vein probably. And this is below frequent complication on insertion. It's just that it's actually inserted properly, but because of the angle, it won't serve its purpose and you wouldn't be able to retrieve the patient. So a case of chronic lung failure, and this is where I let my colleague take over. Yes, we do consider it for chronic lung failure now, but it's a different type of approach. Let me just give you the mic.
I could yell.
You could yell. People around the world can't hear you.
They can't hear me. Okay. So I'm actually going to talk about the case that, let me put this on my shirt here. I'm going to talk about the case that Anne-Marie spoke about with the pneumococcal sepsis, but just let me pop through as to where we are with things. So in the past, so what we do today is we individualize our reasons for putting patients on ECMO. We don't have a set algorithm anymore. We used to have in the past a set algorithm, but now we do it patient to patient, and it's kind of customized depending on what that patient looks like. So you can't say they have cancer, I'm not going to do them. And you can't say they're immunosuppressed, and therefore I'm not going to do them. You can't say they're coagulopathic, I'm not going to do them. You have to decide beyond that what else is going on with them. So in the past, these were the criteria. Look at them all, everything that we would exclude. And if we look today, everything that we go ahead to exclude is a lot less. The only thing that's really bolded there is major CNS hemorrhage. We all would agree, no, we should not go forward with that regardless of how customized that diagnosis is in that patient. But everything else is debatable, and including this low medical certainty of quality of life, which many of us would agree that we still push, I think, in this institution, very rightly so, to try and transition in patients where they have complex medical disease and they have a low quality of life to not do it. And but other centers are doing it. And is it right or wrong? I don't know, but it's forging along that. So what you need to see here is a little bit of history. This is the Branson lung. The guy's head is right over here. It was the first ECMO case actually done. It wasn't a neonate, it was an adult. And this Branson lung is huge. We've gone and gotten better. We don't have to actually prime circuits as much with so much blood and take up half of the bedside space to try and support the patient for oxygenation. Now our lung is pretty tiny and it sits right here, centrifugal pump. You can go on transport with it. You can have them walk around the unit with it. And so we have come a long way in surface and circuit technology, and therefore we've come a long way in the types of high-risk patients that we can put on ECMO. So how do you manage these patients? And good management on ECLS means good intensive care management. That is it. We have to be as much on the ball with a patient on ECLS as we are with any other patient in the unit. So you have to maintain their hemodynamics and make sure they're warm and well perfused and have good pulses and all of that. And you have to manage their fluids and don't let them get overloaded, and you have to restrict. And you have to enterally feed them. It is paramount that you provide nutrition to these patients. A lot of centers still across the world, once a patient goes on ECMO, place them on TPN. Doesn't make sense. The goal here is to try and keep every organ system stable and vital, or help it recover if you're putting them on when they're in multi-organ failure, so that the only organ failure that you have to deal with is the lung failure, and give that time for recovery. You want to avoid infections. That would be great. Since I am the medical lead for CLABSI, I would prefer you guys avoid infections. And then monitoring for CNS events. And if you have an alert or a patient that can move and that you can examine, then you have your best monitor, which is a neuroexam for your patient. We have NIRS, we have experts in neurointensive care here at Sick Kids. All of those things should be invoked in the practice of managing these patients. So what you do when you put your patient on ECMO isn't just stall. ECMO is an oscillator, a ventilator, or whatever else you want to call it. It is there to support the lungs while you treat the cause. And so in this instance, this is a picture from Michigan, but we've got renal replacement therapy, we've got plasmapheresis going, we've got a lot of stuff, and we can't see the patient in behind here. They're a little smaller than all of the equipment around there, but everything has a purpose in terms of supporting this patient and ensuring the recovery. And so you need to continue to go forward. If you have a patient who's septic and you believe that you want to plasmapherese them, you plasmapherese them. If you have a patient who has acute kidney injury and you cannot remove fluid with diuretics, then you need to put them on renal replacement therapy. And number one and paramount, I say again, is to provide nutrition. So you can't wait 4 days trying to diurese them and restrict their fluids and not give them nutrition. It's really, really, really important that you keep all the other organ systems well if you're going to embark upon this course. So lung-specific management. This is the hardest thing for a lot of people to do. Sometimes you just have to stand back, sit on your hands. And that doesn't mean not doing all the intensive care that I just spoke about. It means that you may not be able to recruit them in the first 1 to 2 to 3 to 4 days. And sometimes if they really have very severe lung injury, inflammation, necrotic pneumonia, what's happened is the lung almost protectively becomes atelectatic in the recruitable portions. And so what you have are the damaged portions, the necrotic portions, the pneumatoceles. And you need to give that time to recover until you can get there. And we don't see that many of those patients here because we are the first line in this institution to being able to implement ventilatory support on patients. And we are privileged. I tell you that coming from a center where you're not the first line and you're retrieving patients who've been on ventilation and ventilatory support of all sorts for 14 days plus, poorly nourished, falling apart. And if you go back to centers where you're starting to inherit those, you've got to be patient and you have to allow that recruitment to occur over time. So is there a time limit? Used to be 4 weeks. And we'd say you can't see any recruitment and recovery on chest x-ray. We didn't do CT scans, certainly not 15 years ago, not even 10 years ago did we drag patients to CT. If they didn't have recovery, the lungs look whited out, still at 4 weeks, we'd stop. If they had Staph aureus, we'd stop. Doesn't sound very fair anymore when we have patients now that can last for apparently 600 days. I don't know that I would go that long, but there's certainly patients that run for 40 days, for 60 days, for 87 days, and they can recover from it. The decisions on whether you trach or you extubate, I think in children, on the patients who go on with acute lung infection and need clearance of those secretions, they're not going to be able to do it just awake and extubated. They're going to need something else. And so the portal using a trach, and there are differences across the world whether you trach or not. If you have a lung disease where the patient has pulmonary fibrosis in the adult population, you're bridging them to transplant or giving them some support through that. That's a little different. But if you have a patient with an acute infection, you need to get secretions. I think you need a portal in order to do that. Them coughing is the best way to do it. What does coughing do to your circuit? Makes it scream. But if you can tolerate that for the time that they cough and work through that episode and then support them, you have more success than you do if you keep them flat, paralyzed and not moving, and even then just trying to toss and turn them and prone them. You still can't get what you need out. So the crucial step is trying to determine when do you recruit. A lot of groups will go down and do bronchoscopy. They use these percussive ventilators, and some groups have been successful with that as well. And again, it's in an adult population. It's very different than our variable pediatric population, a difference in their pulmonary compliance. So we now do drag them to CT scans, the worst thing you could do for yourself, because when you look at lungs like this, and then you see the lungs like this kid we never dragged to CT scan. She was 40 days on ECMO. That was the longest we had done at that time. This was in 2009. And then, so at day 32, she looks like this, and you think we're not getting through this. And at day 40, she looks like this, and we decannulate. And what did we do different? We didn't do a lot different, but we did all those things that I talked about in management, and we're patient. And we did put a bronchoscope down once we saw air bronchograms. We put a bronchoscope down, and we'd suction them, and we'd clear their airways. And this one, she went home. She got repatriated back home. So this is what I'm talking about. This child came in. She came in with RSV pneumonia, really bad area of Detroit, necrotizing pneumonia from the methicillin-resistant staph, purulent stuff coming up her airway. There was nothing but necrotic. And this was her CT scan. And you look at it at 40 days and you say, she can't possibly recover. But she started to, and she was nourished. She had single organ failure, just the lungs. No one was going to transplant this little girl. She was infected, just the lungs. What we did is we took her off all her sedation. We made the nurses stay up at nighttime and watch Dora with her. She had these really cool pink headphones. That was hard to do, but I had her cough. When she coughed, the circuit would go crazy. Physiotherapy was very involved with her. She mobilized, she'd kick her legs, arms. She wasn't just in supine. We tried to negotiate different positioning for her. And this is her a year later at her trach decannulation. No oxygen, no ventilator, no trach. And she was on support for a while. She went home on a ventilator and trach for 6 months. The ventilator was weaned off fairly quickly, and this is her afterwards. Do I know why this happens? As I've gone through and looked at these cases over the time I've had the opportunity to manage them, this is the longest case that I've managed. It's 87 days. And again, comes from a center. We see this. Totally healthy young man. Within 24 hours, his lungs look like this. He's florid sepsis, influenza H1N1, methicillin-resistant staph, necrotizing pneumonia, day 8, day 18, day 21, day 45, day 51, day 65, and now we have a bad infection on ECMO. But during that time, he was up and he was tossing a ball, and physiotherapy was there with OT and talking to him, and he'd get kind of pissed at them at times, but they got him up and sitting up. Still had skinny legs, though, so we got to work on that. And on day 87, he came off. And this is his course, and we did do CT scans, and when people looked at the CT scans, they said he has no lung tissue left, and we all thought, what are we doing here? We started calling in who would want to transplant this young man at 60 days, because 60 days was our longest. Who's going to do a lung transplant for him now? His lungs are destroyed. And no one accepted him, and the family declined. And so we continued on, and he came off, and it took some time. But that day 530, 51, this is how he looks. No trach, no vent, no oxygen. And he's still kind of skinny. You know, his lungs have recruited. So all of that destroyed stuff is destroyed. Massive pneumatoceles everywhere. But the back part of the lung that hid itself from trauma and damage over time, and our persistence to keep the nutrition, the excellence in ICU care there, is what helped him survive it. And that's how I believe some of these patients need to be managed. And in some ways, I look back retrospectively, and I'm glad he didn't get a lung transplant, because he doesn't need immunosuppression now. And he's he's more robust and less skinny than this now. I just saw a picture of this last year. So basically our goal, and this is from Carl Davis in Glasgow, the goal of ECLS, we got to provide a physiologic milieu for recovery. And then we have to decide how long we go for it. This isn't the milieu for recovery, but this was the start of creating that milieu. This is our milieu. We look at risks. I think the benefits outweigh the risks. And when things go wrong, we have to be willing to stop. But we shouldn't be bridging to inevitable death, so we should be proactive in how we make our thoughts and how we decide to cannulate these patients and when we should put them on. Oops.
Thank you very much. Dr. Annich, Dr. Guerguerian, do you have any questions? Dr. Parshram.
The question is about the decisions. I guess there's bridge to decision, bridge to palliation, and bridge to transplantation. Decisions are all of these things. And the question of increasing time. Some of these patients at day 86 discussions and decisions? Because clearly sepsis should be cleared by day 86.
So I don't, there's very few pediatric lung transplant centers, certainly in North America, and there's not a lot more across Europe. So we have the privilege of being in one of those centers here. And in the US, I think there's 3, 4, something like that. There's a lot more patients than that who have this sort of condition. I don't know what the right answer is, Chris. And I would have to say at day 60 for my 87 day on ECMO on that patient, I was absolutely willing to call every transplant center to see if we can get him there for transplant. And it was the family that decided against it because the mom had had a renal transplant and she knew what transplant meant. And sadly, we'd had a young lady from the same town who survived 65 days on ECMO, and so they all believed that this was going to happen for their son. It's just going to take a little longer. So what do you know, I mean, that was sort of a double hit to that. But I think that I don't have an answer. In my gut, we need to look at that. And so Oshri and myself, that's his project, we're looking to try and see if we can identify characteristics that make patients survive long ECMO courses without transplantation and see if there's something we can pull from that. And then we have to go center to center and really dig into those files. And it's not going to be a lot of patients, but what we can identify right now, just cursory quick, I can tell you is that beyond 60 days, the survival is 38%, and it doesn't matter if you're 60 days out or 120 days out, which some of the other centers are. It's not a lot of patients, but the survival is about the same in that group of patients.
So Gail, if the family came forward you at 60 days and said, stop, would you have heard?
I would have stopped. I would have. Yeah, I know. I mean, it's hard, but we did a lot of things that still, for some people, they may not want that. We dropped endobronchial valves, and there were times where you felt like he was suffering because he was a 15-year-old who was pretty alert and depressed about that. He had recurrent methicillin-resistant staph infection, abscesses that would pop. I don't know. I mean, that's a huge ethics.
You had a similar case today.
Yep.
And the family said, this is enough, stop, would you have heard?
It's hard to answer.
Right now, the data, so I skipped over the lung transplant. I think, Chris, to your point, lung transplant still is for chronic on diseases that can't get better. So your question was directed at ARDS, correct? Or? Yeah, because lung transplant is still for, vascular disease that's will not get better, or cystic fibrosis. But to Des's point right now is that these patients that have long-term support and do survive have a morbidity that has yet to be characterized, I would say, in the literature. And even the patients that we've cared for, others have cared for, they're either still on dialysis a year out, on trach and vent. So like the case that you had, that was a very good case, but we've had, and when we talk to colleagues, they're amputated children, which doesn't necessarily mean they're not functional, but it doesn't come necessarily without significant morbidity. So I think that's the reason to potentially still consider, and we do have patients that don't recover still. I think there's a gap in the literature right now. Essentially, we only hear about the good stories. Sorry.
Okay.
Push her off the stage.
You can, if people would like to discuss things with Dr. Annich or Dr. Guerguerian, we have lunch now. Thank you very